who have joined on the through the viewers link, as well as we have our people who are joining in as faculty and experts. So today's session of e-Gurukul, it is going to cover up data regarding gastrointestinal and hepatobiliary system. This is more of an interactive session with two experts we have. I'll be shortly introducing them. We have Dr. Rimjin Srivastav. She is an alumni of BJ Medical College, Pune. I'll just briefly talk about her. She has done her MBBS, PGDMCH, and DNB Pediatrics. She is at present consultant pediatric gastroenterologist, hepatologist, and interventional endoscopist, working at Raipur, Chhattisgarh. If you look at all the various positions she has held in IFE, I think so. I'll really congratulate you, Rimjim, to see you achieve all these things. She has been a president of Raipur Academy of Pediatrics 21 and secretary of the Adolescent Health in 2021, secretary of the Women's Wing of Central IIT 2021, 19 to 21, and Raipur Academy of Pediatrics secretary 18-19. She has been an editor of two journals, which is at such a young age is a great achievement, Rimjim. You have special interest in pediatric hepatology, and she's also authored chapters in the textbooks of pediatric gastroenterology and hepatology. So welcome, Dr. Rimjin, and I'm
Thank
sure
you.
we will all be hearing from you. The second young lady who is there with us is Surabhi Dogra, and she has done her undergraduate from Bharati Vidyapith, Pune, and her MD Pediatrics from MGM Navi Mumbai. I saw Dr. Jitendra, your guide, who joined and then disappeared. Maybe he joined again. Okay, she has been a registrar at Vadia Hospital, Mumbai, and done her fellowships in pediatric gastroenterology, one of which is from the Maharashtra University of Health Sciences in Nasik, and the other one is from Espegan Apollo Hospital, New Delhi, as well as a short stay at PGI Chandigarh as well. She has, to her credit, a lot of achievements as technically she's an expert with all the scopings like Rimjim, and also a keen interest in infant and child nutrition, and well versed with liver transplant as well. So welcome, Surbi, and I'm sure our students will definitely benefit with two young ladies here joining in and guiding them. So we move on to our team who's going to be presenting today. We have Dr. Sangeeta, who has mentored the two postgraduate students, Dr. Shivanjan and Dr. Datta. They are JR3 pediatric residents at BJ Government Medical College, Pune. And also now I can see Dr. Jitendra who has joined. So Surbi is smiling now. Dr. Jitendra, we would like to see you. If you can switch on your.
Good evening, ma'am.
Good
Good
evening.
evening,
How are
sir.
you?
Yeah, so ma'am, here three generations of teachers are here. You are our teacher, and I am Surbhi's teacher.
Good, good. So
Surbhi is
that's
now
how
a
it
teacher.
should be. Yeah. So
Yeah.
you stay joined, Jitendra. You can also participate and ask questions or give your inputs. And
Good evening, everyone. I'm Dr. Shwanjan, JR3, Department of Pediatrics, BJMC Pune. So today I'll be discussing a case about a 3 months old female child, resident of Latur, born out of non-consanguineous marriage, belonging to Hindu community, second by birth order, and history given by mother with chief complaints of white colored stool since day of life 3, and yellowish discoloration of eyes and body since 1 month. So, history of presenting illness. Child on day of life 3 started to pass white colored stool after passing greenish black stools for the first 2 days. The frequency was 4 to 5 times per day, semi solid in consistency, foul smelling, not associated with any blood and mucus. And as the baby was feeding well and no other complaints were there, so parents did not consult any doctor. On day of life 8, mother noticed while changing diaper that child had a mass protruding from the abdomen in the umbilical area, which was progressively increased on crying and decreased when the child was resting. There was no redness or discharge present. For this, the parents consulted to a local practitioner in Latur, where they were counseled regarding the condition and were counseled that this condition is self-resolving and it will get better over time. And at age of 2 months, parents initially noticed white yellowish discoloration of the eyes, which gradually progressed in intensity and involved the entire body, including palms and soles. Mother also noticed dark colored urine staining of the diaper. The
Okay,
portion,
so can I stop you for a minute, Dr.
yes,
Shivanjan? Can you
yes,
go on the first slide? Yeah. So why have you marked in bold non-consanguineous marriage and second by birth order? Is there any significance to that?
ma'am,
You
regarding
wanted to
the
highlight these?
Ma'am, regarding the non-consanguineous marriage, like there are certain familial associations which are associated with disease, like some autosomal recessive disorders. So that is why I wanted to highlight this point. And second by birth order is because, ma'am, but it's not really significant, but just to highlight key, because ma'am, not that significant. Just non-consanguineous marriage, I wanted to highlight. So no
Yeah.
significance.
So
But
before
second,
you, yeah.
no,
So do you want
no,
to say? So while presenting in your exam, if you are not ready with any of the answers, don't try to emphasize on that, because now the your Viva is going to go on first order, second order diseases in first order, diseases in second order.
Yes,
Okay, so the cholestasis case will go away, and you'll have to answer on these order and all these familiar diseases. Okay, so non-consanguine marriage, okay. Uh, why have you highlighted these also? White color and yellowish discoloration of eyes and body.
ma'am, just this was just to highlight the matlab, symptomology for which the child presented to our center. That is
Okay.
it.
So with this history, now you must have known that this is a case of something related to liver. Jaundice is there, isn't it?
Yes, ma'am.
So, but after that, you are given a detail of umbilical hernia. The child is having umbilical hernia, right?
Yes, ma'am.
So you are given a detail of umbilical hernia. So your Viva is going to go on umbilical hernia now. Okay, you want to emphasize that this is a case of cholestasis. By the time you have done the examination, you know the case now. So your diagnosis is like you are sure that it is liver related something. So if you are dealing, you are giving details of umbilical hernia, then that is going to become your chief complaint, because you're giving a detail. Okay, you can skip it. You may not mention it also. Or during examination, you can say that umbilical hernia is there. The mother didn't come to the hospital with a complaint of umbilical hernia, right? The
No,
chief complaint was not umbilical hernia. So why to mention that? No, you can mention that in your examination that okay, umbilical hernia is there, and the examiner will ask you whether you want to do anything about this or not, and you can say no, we don't want to do anything right now.
yes,
Okay. Yeah, the next slide,
second
please.
point, madam, what he can say by defending his second by order of birth is like the mother is already a trained mother. So she will notice clay colored stools and jaundice
Right.
earlier as compared to the if her first child is normal. So she will detect these abnormalities fast as compared to a first time mother. So
Absolutely.
that could be your one of the defending statements. I am pressing on the second birth order because the first child did not have such complaints. And when the second child started having these complaints, so the mother was like too early. She's catching it on day of life 3. She's an experienced mother and she's caught the symptoms early. So I think that could be one of the points which you can give to the examiner. She is the mother for the second time and she is catching the symptoms early.
Also, if you want to emphasize on the history that there is no earlier sibling death, which is also seen in these disorders,
Yes.
you can mention that. And if you want to defend, it's okay. But you must have taken in the negative history that there is
Negative.
no earlier
But
sibling death. Right?
Can you
Proceed.
define consanguinity? Now, since you have mentioned it. Just tell very briefly what is consanguinity and its importance.
Consanguinity means like relation that develops between people who are of the same bloodline or share of same bloodline. So that is what defines consanguinity. So it can be, ma'am, like first degree, second degree, and third degree. So those like marriage in the siblings or like very close. So they are like primary first degree consanguineous marriage, and like third degrees are like far relative,
And
aunt,
How
uncle.
how much genetic material is transferred when you talk of the degrees of consanguinity? Do you know
50%
anything
in
about it? Yes, Nitya?
50% in first degree relative. Then second degree 25%, and around 12 to 13% in third degree.
Okay. All right. Has it got any importance with your chief complaints, talking about consanguinity in this case?
If ma'am any autosomal recessive disease is there,
Hmm.
so it may be uh, passed to generation.
Okay. All right. Related to white colored stool and yellowish discoloration. Okay. Now you have mentioned white colored stools. At this stage itself, do you know any causes for having white colored stools?
Ma'am, first cause like white colored stool itself, like it signifies the pathology, like there is some obstructive pathology of the bile, some disease of the bile. That is why the stool is not being stained, the natural color of the stool. So first would be the liver diseases that I would like to rule out. Second, white colored stools could be due to, ma'am, some not exactly white colored stools, but bulky greasy stools associated with some white component associated with like some pancreatic insufficiency. So, malabsorptive syndromes, congenital pancreatic insufficiencies can result in white colored stool as well because of malabsorption of fat.
Cystic fibrosis is there, bulky, oily stool, white stool.
Okay, all right. Anything else? Just forget the case for some time. But are there any other conditions where you get this clay color stools or whitish stools? Any infections are there? Any other diet related? Anything else which comes to your mind?
Ma'am, diet rich in like fats, if we consume, then we can have white colored stools.
Any case where you really have loose stools, but they are rice water color, rice white in color?
Cholera,
Cholera.
Cholera, you can
yes,
get.
ma'am.
Those are acute ones which are there.
Yes,
What
ma'am.
happens if a child is eating food which is not supposed to be eaten? What is it called? When they eat non-food substances, what is it called?
Pica,
Yeah,
Pica.
so which ones can have this type of color,
Chalk eating.
whitish color?
Chalk eating.
iron, matlab, like children who are iron deficient and all. So pica is associated with them. Matlab this condition, iron deficiency. So they can have white colored stool then.
So chalk, clay, all this mud which is there, if they keep on eating it, sometimes you have intermittent whitish colored stools which are there. So why this thing is important is these are the points you take it in your important positive or negative history. Okay.
Yes, ma'am.
And of
Yes.
course, you said obstructive, so all the causes of obstruction probably which you will deal with. So when you're talking of yellowish discoloration so of the eyes and body since 1 month, so what are those conditions which conditions you will keep in mind? Is just a 3-month-old baby, isn't it?
Yes, ma'am.
So what is the grade of this yellowish discoloration?
Ma'am, it's a moderate grade, ma'am, but it's like it's fitting into persistent kind of jaundice or prolonged jaundice, like
So do you know
persistent.
anything about grading as per IMNCI?
If yellow discoloration is more than 1 month, it It fits in subacute condition.
The IMNCI guidelines are, how are they divided? IMNCI, integrated management.
No. So,
They are applicable for what?
ma'am, respiratory
Respiratory
system.
diarrheal diseases.
So age-wise, age-wise.
0 to 2 months,
Yes, yeah.
2 to 12 months, and about 12 months, ma'am.
Yeah,
Like,
so this is just crossing that 2 month period. But when you have the hands and feet and the soles, they are yellow, it is a severe form. They
Yes,
are the ones whom you need to stabilize and send for further investigation.
yes, ma'am.
Okay, so keep in mind all these very simple questions before we go to the actual hepatology and gastroenterology. Okay, all right, move on.
Okay, suppose this patient presented with yellowish discoloration at day 10 of life. Will it be acute liver disease or chronic liver disease?
I mean, it's depend on the condition at that time. If it may be
Same
physiological,
condition, this same history, only the age is not 3 months, 10 days, or say 14 days.
ma'am, it may be physiological also or pathological also.
Okay.
In physiological jaundice,
Okay. So
if
first, tell me, how will you differentiate at day 15 of life only on history whether it is physiological or pathological? Mother comes with maybe stool color is yellow, you can take, and yellowish discoloration of eyes only by history. Do you want to ask anything else to confirm whether it is? See, all conjugated bilirubin, hyperbilirubinemia is pathological.
yes, ma'am.
Okay.
Yes, ma'am.
Unconjugated may be pathological or maybe physiological
Yes,
also.
ma'am.
Right? You agree to
Yes,
that?
ma'am.
So the mother is coming to you with the complaints that the child is having yellowish discoloration of eyes at day 10 or maybe day 14 of life. Okay. So how will we, on the basis of history, you can confirm whether this is conjugated or not? Because if it is conjugated, you need to do the workup. If it is physiological or if it is not conjugated, unconjugated, then you can wait. As you're saying that you can wait for, you'll try to see whether it is physiological or not.
ma'am,
So what is the one that history?
if it's a case of ma'am, like we can ask the color of stools to the mother.
Stool is yellow. Stool is
Ma'am,
yellow.
then we can ask about the color of urine. If the color of urine is like yellow, so it like indicates towards a conjugated cause rather than.
Always yellow color urine will define conjugated hyperbilirubinemia.
if ma'am, if sclera is stained with
Hmm.
sclera and palm and soles is yellowish discoloration is there, it may be pathological. It is indicate only pathological. Palms and soles indicate only pathological. It's not a
Hmm.
physiological.
No, why did you ask, Dr. Shivanjan? You said about something about urine. Why
Yes,
did you say urine? You said urine if it is yellow.
yes, ma'am.
Okay. So first thing, that all high color urine or yellow color urine may not be because of conjugated hyperbilirubinemia. It may be because of dehydration also. Okay. So if you rule out dehydration, if the child is presenting with jaundice and high color urine, especially if it is staining the diaper, then on history you can be sure that it is conjugated hyperbilirubinemia. At any age presentation, it is at any age you need to work up the child. Okay. The definition that is given, what is the definition given for conjugated hyperbilirubinemia? You have to see after 14 days, right? If it
Yes,
is
ma'am.
persisting beyond 14 days.
14 days.
But this definition was actually given for the field workers earlier.
Yes.
Okay, so this doesn't mean that if the child presents to you at day 10 of life or in the first week of life with conjugated hyperbilirubinemia, you'll wait for another week to define that the child is having conjugated hyperbilirubinemia or cholestasis, and then you will start investigating. You have to start investigating the moment you know that this is conjugated hyperbilirubinemia. Okay,
Yes, ma'am.
and pathological, even if it is pathological, most of the times conjugated hyperbilirubinemia in neonates, they don't go up to palms and soles. It is mostly in the eyes only. Okay, so palms and soles may be clear also,
Yes.
right?
Yes.
Then the question was, child is still having the yellowish discoloration of the eyes and body, including palms and soles, same as it was there at the time of admission. Child is on feeding and accepting well orally. Adequate weight gain is present. Clay-colored stools are still present. Yellow diaper staining is present, and investigations done, which will be discussed later.
So now you're saying clay colored. Earlier you said white color. So is there any difference? And why is this difference of colors come?
Ma'am,
Why
why?
the white has become clay?
We have seen.
You have to stick to one color, right?
Yes,
Ma'am,
This
in course in what we have seen that school color in the history, mother what mother told we have written in that history.
History is always in the language of the
Yes, ma'am.
patient. She will never say clay colored or high colored. She will say orange, ya
no, but
narangi, ya
this you are
white
giving
color.
history, right? History. You have not seen the stool. You will
Yes,
not
ma'am.
see the stool in history. You'll
Yes,
see it later, right? So
yes,
yes,
your
ma'am.
definition of color stool will come later on.
Yes.
Okay.
One
Or
thing
you
in
can say that it is depigmented stool. Mother is saying that it is not yellow. It may be clay, it may be white also. Or sometimes when this it is very light yellow, which is also a depigmented stool, they call it yellow also. So what is important? How many times you will see the stool color, and how for how many days you will see to
ma'am,
confirm it
three
is.
days,
For
three
consecutive
consecutive
It,
3 days.
3 days.
yes, consecutive 3 days. You have to see with your own eyes and not
Yes,
rely
ma'am.
on the color sense of the mother whether it is yellow or not.
Yes.
Okay.
Yes,
Yeah.
do one thing, Shivanjan, just go back to the second slide. No?
yes,
You have over here, you have spelled out over here. Okay, white color, foul smelling.
yes, ma'am.
What does that tell you?
Ma'am, foul smelling, it could be the foul smelling stools, it could be because of an infective cause as well as a non-infective cause. So, foul smelling stool in this setting, like it could be due to, in the non-infective cause, it could be due to some malabsorption that is leading to foul smelling stool. And the most common cause is like malabsorbed fat, which causes foul smelling stool. In the infective cause, it could be the infection that is causing the foul smelling stool.
But in
Anything?
infection, will they have white color stool? If there is infection, what would be the color of stools?
Ma'am, color ma'am, it could be green or it could be like if it's like the lower
Mostly
gel
it
that
is
is
yellow or white, like
like
watery yellow or greenish.
Yes.
greenish. Yes.
Such white. This is the actual picture of the stool, or you have just taken it from somewhere?
No, no, no. This is the actual picture of the
This
stool.
is the actual picture.
Yes,
Yeah. So this color stool, I don't think it will come in any of the infections.
yes,
This is definitely like cholestatic stool.
ma'am. Yes, ma'am.
Because usually when you have this color of stool, na, it is actually odorless.
Yeah.
There is no smell to it. Okay, so this highlights the importance of you history taking because you should know how to answer that. Is it got some infection? Is it got some other ingredients in it which are producing a gas like and which is giving that smell? Okay, especially is it with malabsorption or without malabsorption? Okay, then the color will change. Okay, baby is feeding well, no?
Yes, ma'am.
He said very well,
Pretty
Mother
good.
is
gaining weight
well.
on breastfeeds.
Yeah. Okay, next slide.
Then there is no history of fever, vomiting, refusal to feed, lethargy, constipation, abnormal body movements, bleeding from any side, abdominal distension, or any blood transfusion.
Yeah,
So,
why have you asked all these questions?
yes, ma'am. Fever, we have asked to rule out like sepsis, which is like a commonest cause, like presenting with jaundice. So, fever, jaundice for the infection, sepsis. Vomiting, we have asked to rule out about some inborn errors of metabolism, like metabolism, galactosemia, tyrosinemia. And also, vomiting can be associated with some obstruction, like pyloric stenosis and all. So that can also present as jaundice. Then refusal to feed, lethargy, also
Why
features.
pyloric stenosis will present as jaundice?
Ma'am, because of ma'am increased intrahepatic ma'am circulation will be.
No.
Pyloric stenosis is not present with jaundice. And what is the age of presentation of pyloric stenosis?
Ma'am, usually it presents around after 6 to 8 weeks.
Child is 3 months, you would have presented earlier,
Early.
and they will not present with jaundice.
Yes, ma'am.
Do they present usually pyloric stenosis?
Sorry, ma'am.
How
How
does
do
a child with pyloric stenosis present to a doctor?
Ma'am, abdominal mass with
Vomiting will be there. There will be non-bilious kind of vomiting, and there will be like visible peristalsis can be there, or the child will be like not able to gain weight, failure to thrive, which will be there, and
If you are asked to describe the vomiting, what word is important? Or how do you describe that whole mother? Describe it very well. She feeds the baby and then what happens?
projectile
Projectile non-bilious one.
Yeah,
vomiting.
very good. There it is projectile, Rajat. Yes, it is non-bilious
Yes, yes, ma'am.
and
And associated with visible peristalsis.
Peristalsis, which cause
yes, yeah, failure to thrive. And then gradually what will happen is somebody has written acidosis. So they will keep having a low-grade tachypnea, which is there. Okay. So
yes,
projectile, non-bilious failure to resulting in failure to thrive if nobody diagnoses on time. Okay. It is not a DD for jaundice. Okay. Yeah, go ahead.
then the constipation, ma'am, we have asked to to rule out conditions like hypothyroidism, even.
Refusal to feed and lethargy. Did you
Ma'am,
skip that?
no, no, I've said, ma'am, it could be because of the sepsis component itself, or it could be due to some metabolic disorder like galactosemia, dyslipidemias, and all.
And and
Ma'am, fructosemia.
and
fructosemia, 3 month
yeah,
old child.
3 months old. What is fructosemia?
Fructosemia, just
What happens in fructosemia?
Ma'am, actually, it usually occurs when the like child is weaned off from that milk, like to from the breast milk to the complementary diet. So at the time of weaning, this happens. The symptoms are more.
No. If the child is weaned with cereals, will the child present with fructosemia? What
No,
is one thing that will precipitate it?
ma'am, like juices and all, if it's there
So
in the
unless
body,
until they are given juices, they will not present with this.
present.
Okay.
Yes, ma'am.
So you can say and lethargy, refusal to feed in case of cholestatic case is very important if the child is having whether the child is having acute liver failure or not. Okay, if the child is in liver failure, the child may have refusal to food, not always. It may have or may not have also and lethargy also.
Yes,
Okay.
ma'am.
Why constipation?
Ma'am, to rule out hypothyroidism. So if because jaundice in this setting, it's also associated with hypothyroidism. So constipation is a known feature. So that is why we have asked about constipation.
It's a very rare cause of cholestatic jaundice. So you can keep that down in the count.
Ma'am, then abnormal body movements, like due to the complication also, ma'am, like hypoglycemia, as a part of sepsis, hypoglycemia can be there, so child can present. Even in the inborn errors of metabolism, the metabolic disorders, abnormal body movements can be present. Then bleeding,
And what else can cause
intracranial,
seizure?
if any intracranial bleed is
bleed
there
is there.
in
Yes.
sepsis.
So are you every time you are giving you know that baby had sepsis? The baby had sepsis?
No, ma'am.
No, no.
No. So every time you are giving the reason of that sepsis can have lethargy, sepsis can have abnormal body movement, so your case will go on sepsis. Okay, so you know that this is a cholestatic neonatal cholestasis. So with respect to that, you have to explain what are the negative history. Okay, so abnormal body movements first will be intracranial bleed because of why would there be intracranial bleed?
Ma'am, acute liver failure.
The complication, ma'am,
Complication.
acute liver failure.
No, no, acute liver failure may not have bleed. No, not raised IC.
Connected.
Why
No,
would
not
there be
raised
raised IC?
ICP.
Why would there be raised IC?
Coagulopathy.
Yes,
Kernicterus.
coagulopathy, not kernicterus. Why
Kernicterus,
kernicterus will
Guys,
happen in
conjugated
conjugated?
hyperbilirubinemia,
It will happen in
kernicterus.
unconjugated. Okay. You said, Dr. Rajat, that coagulopathy can present in any cholestatic baby, whether it is whatever the etiology is. Okay. So because of coagulopathy, they can present with intracranial bleed, and they can because of that they can have seizure. Not all IC bleed will present with seizure also.
Yes.
Okay, so because of that, they can have seizure. So it's very important that whenever you see a child with neonatal cholestasis, first thing you have to do after taking history and examination, to take the sample and give a shot of vitamin K. Okay, 2 to 5 milligram. This is very important because there are deaths before you have all the investigation and before the diagnosis is made, they bleed to death. Okay, so the moment you see the baby is having cholestatic jaundice, collect the sample and give a shot of vitamin K.
ma'am, then bleeding from any site, I get to rule out complication like acute liver failure, zero DIC, if like
Not acute, don't say acute liver failure. You want to rule out coagulopathy.
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 It is different
Coagulopathy.
from acute liver failure. Okay, what is acute liver failure? How do you define acute liver failure?
Ma'am, in setting of children, like if the we like look at the prothrombin time in the INR and like less than 28 days, if child is presenting with deranged PT INR associated with
What is the cutoff?
ma'am,
What do you mean by deranged PTINR?
ma'am PT more than 15 seconds.
And
And
INR?
ma'am, INR more than 1.5.
Hmm. So more than 1.5, a child is playing well. Will you label it as acute liver failure?
With bleeding manifestation.
No, the child is not having bleeding. Okay, so the definition of acute liver failure in children is the INR. There's no role of PT also. Okay, you have to see the INR. If it is more than 1.5 and the child is having encephalopathy,
Encephalopathy.
then it is acute liver failure. Or if the INR is more than 2, with or without encephalopathy, that is acute liver failure. But on the first go, if the child is presenting to you that the child is presented to you that it is with a say INR of 2, on the first go, you don't have to label the child as acute liver failure. What is that? It should be not correctable.
Correctable.
So if the child presents to you with INR of more than 1.5 or 2, first thing you have to give vitamin K 5 milligram to 5 milligram. Okay, 5 milligram is correctable, and older children you can give 10 milligram. Repeat the INR after 6 to 8 hours. If the second INR is still more than 1.5 with encephalopathy or more than 2 with or without encephalopathy, then you have to label the child having acute liver failure. All acute liver failure will present with bleeding. It's not that.
No.
They may or may not present with bleeding. They may have coagulopathy. Coagulopathy is there. If INR is more than 1.5 or 2, coagulopathy is there. But all of them will not present with bleeding. Okay, and all of them will not have encephalopathy also. So acute liver failure is not synonymous to encephalopathy. Even in older children, they may have INR more than 2, and they are stable. They're playing well. Okay,
Yes.
so for this bleeding for inside, you want to rule out whether there is any coagulopathy or not. Whether there is coagulation disorder, that is INR is deranged or not. Don't talk about PT also. Okay, so talk about, because for INR, what is INR? It is internationalized normal ratio. So this is the standard thing. PT depends on the what level they have taken. The lab depends on the lab. Okay, so INR you have to use a word. So if INR is deranged, that is coagulopathy. All coagulopathy may or may not present with bleeding also. Okay, so what is the typical bleeding which is seen in cholestatic babies? There is a term for that. And how would the mother tell you that, or what history you will ask to confirm whether the child had any bleeding from any site or not? If you ask the child whether there was any bleeding, she'll say no, but there still could be coagulopathy. There still could be bleeding. So what is that history you'll ask? How did you ask this mother whether there was bleeding from any site or not?
Ma'am, like we asked about the color of the stools, whether they are black colored stools or not.
It's white. It's white. She
It's
said
white.
white,
Black
no?
stools and
Then any bleeding, ma'am, from the like nose or the umbilical stuff that is there, the earlier when it was there. So any bleeding from that side, or any bleeding from the gums, or
So cholestatic children will, in very severe cases, and where the INR is deranged very severely, then all these things will be seen. Initially, they'll present with subcutaneous bleed. Okay, they'll have blue patches over bodies.
ecchymotic patches
Yeah,
they will have.
big patches. That's called blueberry muffin. Blue nodules would be there, which turns black later on. So they'll tell you, yeah, bluish patches. He had bluish patches and now it is recovered. They'll say this. Okay, so this is bleeding actually. She will not know that this was because of blood, because of subcutaneous waste. So you have to specifically ask whether the child had any blue patches over the body in the past. The child is 3 months old. He may had coagulopathy and they recover it also. Or somebody gave vitamin K outside and for some reason, so it subsides also. Okay, so when the child will come to you, you may not see. So it is specifically asked about the skin bleed. Okay, all these things. If the child had black stool, mother would have told you the child having black stool also. Bleeding from nose, then child will not be very stable. Okay, but a child who is bleeding, having subcutaneous bleed, they may be stable also. Okay?
These are like the first markers, ecchymotic patches. If your
Yes.
child is bleeding, IVH happens rarely in cases of deranged coagulopathy. It is very rare, less than 5%. But if the child is bleeding from the nose, if you're having black colored stools, then you know the child is already late when he's coming to you. I'm sure madam will agree. So rather than asking those extreme things, you have to first ask whether he's not developing patches or anything, because initially they won't have mucositis. And what is the cutoff in neonatal acute liver failure for INR? Like sometimes there are
premature neonates sometimes. So what is their INR cutoff? Is it the same?
Say some figure, no?
yes.
You are mentioning
Maybe
about
right also.
galactosemia, tyrosinemia, everything you have mentioned, but it should be something must be different, no?
Age wise,
Preterm in preterm less than 2 INR is
If we have already decided that it's 1.5 and 2, it will never go down. No, you have to give some increment. Take a guess. You may be right.
2.2 to
ma'am,
1.
2 to 2.5.
Thoda और.
2 more than 3.
Three or
Some
more
say,
than three.
3.
some say that neonatal can be taken as 3 also.
Three. You said those things which are seen in neonates, so we had to ask that question. You so in Viva you should know what you are walking into. So don't say such things.
Okay. Why abdominal distension?
Abdominal distension due to the complication of the liver failure, ma'am, resulting to ascites. Could be ascites, ma'am, abdominal distension or
Why liver
hepatitis.
failure will lead to ascites? Or
Ma'am, like
will
in
liver
this,
failure
ma'am,
will
like in
it,
this condition, like child has presented to us at age of 3 months. So, like if the child condition was ignored, so like the cirrhosis would have set in, and if the cirrhosis would have set in, then the protein levels, the synthetic functions of the liver will go down, and so due to hypoalbuminemia and less protein, the abdominal
so
distension.
what you are describing is the pathophysiology of portal hypertension. It's not of acute liver failure. Okay, if the ascites is there, that means the child has already had developed portal hypertension.
Yes, ma'am.
Okay, so he's having ascites, splenomegaly would be there, and cirrhosis is there. It's not the sign of acute liver failure. I told you that in acute liver failure, the child is having INA more than 2. Child would be very stable most of the time. Child is playing well, there's no ascites. Okay, it's later that they start decompensating if you're not taking the right measure. Okay, okay. What else will lead to abdominal distension?
Them as a part of hepatosplenomegaly and large liver.
Absolutely. So if the liver is so enlarged that can also give you are asking mother, right?
Yes,
So
ma'am.
that mother will say that yes, abdomen is distended as compared to before. Okay. Yeah. Any tumor can be there.
There
Hepatocellular.
could be a compression due to the tumor, so that can also cause, like, because in the setting of white colored stools, so there could be a mass compressing on the bile duct, which is like obstructing the flow of bile, and also it's enlarging over a period of time. That can cause abdominal distension.
Very less likely. Very less likely in small children. Is it a cause of cholestatic jaundice in newborn? Mass pressing.
No, ma'am.
So you know that cases of neonatal cholestasis. So you have to rule out things. You know the causes now. You know the etiologies. What are the causes of neonatal cholestasis? So you have to rule out those things. Rest of the things. Okay. So basically, when you try to rule out what should you try to do? What is the classification of neonatal cholestasis syndrome given?
Ma'am,
Hmm.
ma'am, if the child is sick or child is not sick, so if
No, this is
the
not. This is for the management.
yes,
What is
ma'am.
the classification of neonatal cholestasis? The very good chart is given in Nelson.
Ma'am, classification. Ma'am, classification you're asking?
Yeah.
Classification of cholestatic jaundice.
Yes. So one is hepatocellular.
Yes, ma'am.
Extra
Yes. What is
hepatic.
the other one?
Extra
Extrahepatic.
hepatic.
Yes. So on history, you have to decide whether it is hepatocellular or extrahepatic.
Yes.
What is one thing that will decide whether it is extrahepatic or not? What is the cause for extrahepatic cholestasis?
Ma'am,
Most common cause is the surgical cause.
biliary
What?
artery
Extrahepatic
excision,
biliary atresia.
Okay.
choledochal
So
cyst,
one thing that will decide whether it is hepatocellular or not is
clay colored stool. मतलब
clay color stool can be there in hepatocellular also. But if it is pigmented stool is there and you are sure that it is pigmented,
yes, ma'am. तो
so that's why you have to see with your own eyes, then it will rule out the
cholestatic jaundice.
The
biliary. Yes.
extrahepatic biliary atresia.
Cholestatic तो दोनों है,
Yes.
है ना? The biliary part, that is also known as obstructive part. Okay. So if it is pigmented stool, obstruction के आपके जितने भी DDs हैं, biliary atresia, choledochal cyst, inspissated bile, all these are ruled out. Then you have to focus now on the hepatocellular causes.
Yes, ma'am.
Okay. What are the causes in hepatocellular?
Ma'am, it could be metabolic cause, it could be due to viral illnesses, and it could be idiopathic neonatal hepatitis.
कॉमन थिंग्स फर्स्ट. तू मेटाबॉलिक पहले मत डाल. जो तू कॉमनली वार्ड में देखता है, तूने आईसीयू में देखा है, वो पहले डाल.
Okay.
What is the most common
ऑलवेज
one?
कॉमन
Ma'am,
थिंग्स फर्स्ट.
ma'am, sepsis, torch infections.
Okay, so torch infection is now not taken as cause for cholestasis. All the torch infection. Okay, only few viruses like cytomegalovirus, Coxsackie, herpes. Okay, so you have to rule out these. Torch is not taken. Don't mention torch word. You have to say, you can say viral infections.
Viral.
Okay, so sepsis, infections, metabolic, all these things are there. So in a negative history, now you are sure. Now there is clay color stool. Okay, so it could be hepatocellular also, and it could be obstructive also. But had it been a pigmented stool, then you shouldn't have thought about the obstructive part.
Yes.
You should rule out infections, IU infections, metabolic. You have more negative history, or
No.
this is all. So you have not taken sibling history, sibling death, any similar disease in the sibling. If there
मैम
is
आई
any auto
थिंक
Ma'am, it was
फैमिली
in
हिस्ट्री
family.
में बोलते हैं मैम. शायद
family history
फैमिली
बोलेंगे.
हिस्ट्री में वो चार्ट बनाएगा ना, तो शायद बोलेगा उधर.
Yes, ma'am.
I think यहाँ पे you should rule out. आप चार्ट बना के बता दो, बट क्योंकि क्या ना, now the examiner will have to wait for the family history to come. That time will he mention or will he not mention? Okay, so why are you trying to take the negative history? Because you want to streamline your differentials,
Insurance.
right? अब family history तक wait करेंगे कि whether it is autosomal recessive or not. Okay, you can mention it here. If you want to mention it, as I already mentioned in negative history, there is, you can mention one line there also. Okay, so negative history is to streamline your differentials. So after negative history, you should be sure that in which way I have to go.
Yes.
Okay, why blood transfusions?
Ma'am, to rule out pre-hepatic cause like hemolytic anemia in cases like hereditary spherocytosis and all, they could be hemolysis leading to
But
jaundice.
will they present with conjugated hyperbilirubinemia?
No, ma'am. I'm unconjugated just to like complete the list, so that is why.
But see, after history, you should be sure whether you have to ask about unconjugated or conjugated. Now the child is having clay color stool, child is having jaundice. Okay, at 3 months of age. Had it been hemolytic anemia, he would have presented much earlier,
Yeah. Yes, ma'am.
right? And he would not be stable like this. So now you are sure that it is cholestasis. Conjugated hyperbilirubinemia is there. Okay. Viral infection because of blood transfusion with the CMV. No, CMV will not transmit by blood transfusion at this age. Okay. So blood transfusion, you can ask for blood transfusion in a cholestatic baby. Why?
Ma'am, can you please repeat the question?
You can ask for blood transfusion in a cholestatic child. Why? For what? Okay, the mother says the blood transfusion was there. What will that signify? At 1.5 months of age, child was admitted for something, child was having jaundice, and the doctor transfused the child. The mother is giving this history. She doesn't know why was the child transfused, but the child was given transfusion at that time. So what will that signify? Child had bleeding. HB was low, that's why he was
Yes, yes, ma'am.
transfused. Why was HB low? He had bleeding.
Yes, ma'am.
He bled from somewhere, which went unnoticed. The doctor transfused, the baby was well, and he was discharged. Okay, so at this age, okay, what hemolytic? Okay, suppose the child is having hemolytic condition. It is a very rare condition, and the child present with cholestatic neonatal cholestasis. What is that thing called?
Ma'am, gestational alloimmune.
No, they don't have hemolytic condition. That's a different thing. There's something called inspissated bile duct syndrome, okay, where there is sludge formation because of intrauterine hemolysis, and the sludge is so hard that it actually makes a plug in the biliary tree. Because of that, there is stasis of the bile. Okay, a very rare condition. It's a very rare condition. So if you want to defend that why I asked blood transfusion and all this, then you can say, but better not to mention this. Okay, or if you want to mention, then you can say that I just wanted to rule out if the child had previous admission somewhere, you can rule out whether the child was transferred because of bleeding or not.
Really?
So Shivanjan, the best way was to just write there was no previous history of any hospital admission.
Yes.
Yes, ma'am.
All these questions would have been avoided in your final examination.
Or you
So
should be ready with your answer.
तो ये तो 5 मिनट तो फंसता ही नहीं तेरे वाइवा में. So
Actually,
simple.
it
Next
should.
time remember no history of, so there would be no blood transfusion. Nothing would have come up, and you would have moved on to the next.
In fact,
You should
you have written
never let
bleeding.
the examiner rack you on one point, which I'm sure madam must have told you. Never let them rack you at one point.
Okay, what you've written bleeding from any side. Don't mention this. You can write there is no history of bleeding. Okay, this blood transfusion thing can come into that also. You can explain that and that if there is previous admission that there was no blood transfusion given, there's no blue patches on the body. These things you mention. Yeah. Sibling history, I think you should mention here only.
Ma'am,
Because that is a very important history in as far as polycystis is concerned.
ma'am, sibling history. There were no similar complaints in the sibling. Her sibling is 3 years old. She just had a history of like the hernia only, umbilical hernia,
Yeah,
which
yeah.
got
This
resolved after
detail you
six
can give in
months.
the family history. The
Okay.
examiner wants to know whether there is autosomal recessive condition involved or not.
Ma'am, no
So
similar
simple,
conditions
yeah.
in the sibling.
So no sibling, no history of sibling death or similar condition in any of the siblings. If the child is second order, so the detail you can tell in the family history. Yeah.
Uh, then the birth history. In the first trimester, mother has a history of cold, cough, and fever, but no rash, for which mother was admitted for 4 days in view of viral URTI. Mother's blood group is B positive. No other drugs other than iron and folic acid taken. Decreased blood supply to baby in utero in the third trimester, as told by the doctor to the mother, was there. Then the perinatal history, child
Okay,
was
wait. So why do you want to ask antenatal history? And what is one history which you have not asked, which is significant in case of cholestatic case?
ma'am
Why
in
do you
the
want to ask antenatal history?
Ma'am, first, like in the first trimester history, I would like to rule out infections, the torch infections history, because these present with fever and rash in the first trimester. So that is why I asked about the first
So
trimester.
see, in one line, there is no history that confirmed there was any infection in mother. That's it, finish it. If the examiner asks you, what did you ask to confirm this, then you can go in detail. Okay, there is no history suggesting there was any torch infection. Okay, but there is one history which you have to ask in mother if there is a cholestatic case. What is that history?
Ma'am, in the third trimester history of pruritus, if the
Yes,
mother is having
yes.
itching.
Yes,
So
ma'am.
what is that called?
Ma'am, it's
And what is its significance?
Ma'am, progressive
familial intrahepatic
intrahepatic
cholestasis with case may it is seen,
AC.
ma'am.
What is the condition called in mother?
Condition called in mother.
Yeah.
No, not
No,
fatty liver
not fatty liver
disease.
disease.
It's called ICP. What is the full form of ICP?
Nice.
Intrahepatic cholestasis of pregnancy.
Pregnancy.
Okay. So mostly they present in the third trimester with pruritus, and after the baby is born, it subsides. Okay. And what doctor was saying that these children may present with, you were saying PFIC. What is PFIC?
Progressive
Progressive familial intrahepatic cholestasis.
Policies. Okay, so this is one history which you have to you have to mention that there is no history of intrauterine infection, torch infection, and there is no history of ICP in mother also. Okay,
Yes.
yeah.
Then the perinatal history. Child is full term, born out of LACS in view of fetal distress. Baby cried immediately after birth. The birth weight was around 2.5 kgs. There is no history of an ICU stay. Child was breastfed immediately after birth. Child was discharged after 3 days from the hospital. Child is immunized till age of 6 weeks as per national immunization schedule. Developmentally normal as per age.
Okay, so what is the significance of perinatal history?
If the child is preterm or not, then
Yes. So
mode of delivery. It's
Then
okay, the child is
Homologous
preterm then.
covering.
mode of delivery, ma'am.
No.
Normal.
If the child is preterm, then
Ma'am, more chances of hypoxia and intracranial bleed is there. Hypoxic insult is there.
hmm. So
Then
what happens? Why hypoxic insult will lead to jaundice?
uh,
Ma'am, actually, if child is free term, so like first is the like RBC, the lifespan of RBC is much lesser in free terms. So
So will present with unconjugated jaundice, no?
yes, ma'am.
Why conjugated jaundice? You're right. You were saying what's your name?
ma'am,
Huh?
Datta.
Datta. Okay, Dr. Datta. You were saying you were close to that. So child is having, so for perinatal history. Okay, preterm is there. The child may have asphyxia. Okay. So what will happen?
Ma'am, intracranial bleed is there. RBCs break into
All asphyxia will have intracranial bleed.
No.
Then there is insult to the brain. Why is there insult to the brain? And what happens in other systems because of that HIE?
Like there is injury to the heart, there is injury to the liver. So
First say liver. Now we are discussing about
Yes,
liver.
ma'am.
First say
no
liver.
vitals, yes, ma'am. Liver and heart.
So what happens in liver? There is ischemic insult to the
Insult
liver.
to the liver,
Yes,
yes,
ma'am.
ma'am.
Okay, so that can lead to jaundice because of the ischemia,
Ischemia.
right?
Yes,
Okay,
ma'am.
what else? What else? The child breastfed immediately after birth and child was normal. You have to say that. Why? The child did not have any symptoms at birth after breastfeeding. Why? Is it important that child breastfed? The child was given breast milk and the child was normal. Why do you want to know that?
Ma'am,
Obst-
if there is obstruction is
obstruction.
there, they
Where?
if lactose
Obstruction
intolerance
where?
is ma'am, in the GI tract.
No, like duodenal atresias and
Okay,
all that.
what obstruction in GI tract will present with jaundice?
Baba, don't forget jaundice.
Yeah, we are
Jaundice
talking about
है
jaundice now. What obstruction will lead to jaundice?
Ma'am, biliary tract.
Ma'am, duodenal atresia.
You are making yourself land into a big mess, okay? Don't utter anything if you don't know how to defend that. Okay. If you stay quiet, that is safer. Okay. How will taking breastfeed or not will decide whether biliary tract is patent or not? You said that, no? So suppose the child takes breast milk and he becomes sick. The child is given breast milk and he becomes sick. Why will he become sick?
Ma'am,
What
inborn error of
condition will lead to? Yes. What
galactosemia.
inborn error? Yes, absolutely.
Galactosemia.
Yes. Okay. So this history is very important. You have to say that child was breastfed immediately after birth and after that also, and the child remained stable. With this, you want to rule out that there was no galactosemia. Okay. If a child who presents at birth is given breast milk, whether the child is having, the child may become sick because of any cause. Galactosemia also, child may have acute liver failure at birth also for other reason. So if there is a sick child on day 1, 2, 3 of life and you find that the child is not normal in a cholestatic child, first thing you have to do is stop breast milk. Unless and until you prove that this is not galactosemia, don't restart with breast milk. Okay? Because if in a galactosemic child, if you stop breast milk, child is going to improve. So by the time your investigations come and you are sure that this is not galactosemia, don't start with breast milk. So a sick newborn with cholestatic jaundice, you have to stop breast milk immediately, unless and until proven that this is not galactosemia. Okay, child was discharged after 3 days. So there is a significance to that. Child was well at the day 3 of life. That's why he was discharged. That means there was no problem with the breast milk. There are rare varieties of galactosemia also, which can present later on, at after 2 to 3 months also, but they are not very sick. Okay, they tolerate breast milk. But the classical variety which we see, they will become sick within 24 hours of accepting breast milk. Okay, yeah.
What is the significance of that immunization history? You've written that the child is immunized till the age of 6 weeks and the child is now 3 months old.
Yes, ma'am.
No further vaccines given?
No, ma'am. Till 6 weeks only. The last dose was given at 6 weeks.
Yeah, why is it important? You all are all sitting in the OPD, isn't it?
Yes.
What is the vaccine schedule?
Ma'am,
After?
at birth, we give ma'am BCG,
BCG.
Yeah,
hepatitis
that's all
B.
right. Like after 6 weeks, when does the child come again?
About 10 weeks,
10 weeks,
10 weeks, 14 weeks.
14
14
weeks.
weeks,
Yeah.
then
Where was this vaccination given?
ma'am, in the hospital in Latur only.
Latur only.
Yes,
So
ma'am.
does anybody see the baby at the time of vaccination?
Ma'am, mother was there, ma'am.
Who gives the vaccine? The doctor gives the vaccine. Residents write also NAD and send to the immunization center without looking or opening up the baby. Do you think this jaundice would have been picked up by somebody if the baby was vaccinated? 6, 10, 14. You see, the mother is coming to you at 3 months of age and they knew that the baby is yellow, isn't it, before that? So that is the importance of you all going for OPD. When healthy babies come to see whether fit for vaccination, you should examine each and every baby, not just ask the mother. Okay,
Yes.
this baby could have been picked up at 6 weeks, 10 weeks, and 14 weeks if a proper history was taken, examination was done. If the nurse who is giving the vaccination undresses completely and has a look at the baby, okay, they would have picked up the jaundice as well, isn't it? And the history of having passing stools which are white colored, they could have asked the history also. So history for even a normal looking baby is important. Examination is important. Okay, you can prevent delay in diagnosis.
Diagnosis.
Okay, go ahead.
And what is your personal opinion if the child has neonatal cholestasis, is thriving well, as you said, growing well, gaining weight well?
Yes.
So what is your personal opinion? Would you go ahead with the vaccination, or you would tell the mother that I will not be able to vaccinate this child, or he should not be given vaccination?
Ma'am, personally, I think child should be vaccinated. If like there is no like absolute contraindication to it, it should be vaccinated. So just because child is having this condition doesn't like not make him candidate for vaccination. So I think, in my opinion, I would have given vaccinations.
Yeah, developmental history you missed.
Normal.
Ma'am, normal, developmentally normal as per age.
Why do you want to know about developmental history?
Ma'am, child is thriving well or not? Achieved milestone as per age or not? If child is sick, he will not be able to achieve the milestone as per his age.
So it is not achieved, then what will it signify in a cholestatic baby?
Ma'am, will investigate for the further management like metabolic workup,
Genetic condition.
Genetic
genetic
conditions.
conditions.
So if the child is not developmentally normal, so at 3 months there are a lot of things you can assess.
Yes,
Okay,
ma'am.
if the child presents at 15 days, 1 month is difficult to assess whether the child is developmentally normal or not. So your genetic disorder should be higher on the cards if the child is genetically abnormal. Okay. Hypothyroidism, somebody mentioned hypothyroidism. They will not be like they will have normal milestones by 3 months. Later on, they will know that the child is having any cretinism or not. But at 3 months, you won't be able to detect hypothyroidism only on the basis of developmental history, right?
Yes,
Ma'am, they develop, usually they start develop cretin features, coarse features by 3 months. So physically we can actually see those hyperthyroid babies. They start almost developing those
That
features.
course
So
fine that will start from birth only, no, not
yes, ma'am.
mother will
Yes.
see that the cry is different, child looking abnormal, and
Yeah.
somebody would have picked it up. Okay. So very important is that rule out by taking development history whether there is any genetic condition involved or not. There
yes.
are many genetic conditions in which the child may be developmentally normal also. Okay, but the child is not. If the child is not normal, then your genetic disorder should be. You should keep that in your mind for, during investigations. Yeah.
Dietary history exclusive. Child was on exclusively breastfeeding. Passes urine 6 to 7 times a day. Passes stools 4 to 5 times a day. There was no history of cow milk or formula milk feeding. Total calorie intake is approximately 638 kilocalories, and the protein intake is 6 gram. And the required for this age, the calorie intake is as per 100 kilocalories per kg per day. Required protein is 2 gram per kg per day. So there was no deficit in the calorie intake, and there was approx 4 grams of deficit in protein intake.
But how will you know the quantity of breast milk child is taking in one go?
Ma'am, actually, we have calculated around, if the child is full term,
20
the normal output is around 400 to 600 ml of breast milk in
within 24
within
hours.
24 hours. So, like 100 ml, we know the kilocalories, it's 67. So, we have like multiplied it by the
Wait.
respective number, the 5 or 6, the 600 ml, we have, because child is thriving well. So, we have picked the maximum number. So, we multiplied it by 6, then we have calculated the calories. And
So,
similarly, the proteins.
like my only doubt is to Aarti madam is like, since madam he is only 3 months and the child is thriving well, so do they need to give in a calorie requirement for a breastfed child at 3 months of age also? Because we never used to give since he is only on breast milk. So that is only.
If you know the answer what Shivanjan told us now, then only
Yes,
utter it. Otherwise, you have to say that is a thriving baby only
yes,
on
ma'am.
breastfeeding. And if you're asked on it, then you give the explanation. Because see, in this case, you want to go very quickly to differential diagnosis, examination, and score over there. So these are places where unnecessary you get caught. Your answer is correct.
Correct.
Okay, your answer, what Shivanjan gave is correct, the calculation. But you could have just said that is exclusively breastfed and thriving. Okay, so that is there. If you are asked, then give it that it could be approximately. But the same child, if there was failure to thrive, of course you have to give that. In fact, that child will be kept for exam for failure to thrive rather than all this. So there you have to maternal health comes in, how many times she feeds, how much time each feed she gives. So we can have that type of a case next time, failure to thrive. Okay?
Yes.
You are right, Surabhi, that we can get away by saying thriving well, exclusively breastfed.
Because
Okay?
these cases come as a short case. Your cardio and neuro are your long cases. So you know these are scoring cases. So chalo next slide.
In the family history, there are no similar complaints in the family. Elder sibling had a history of umbilical hernia, which resolved after 6 months, and there was further significant complaints. Then, I belong to, according to modified Kapuswamy scale, to class 4, which is upper lower class. Then the anthropometry, weight is 5.2 kgs, length is around 59 centimeters, head circumference is 37 centimeter, and so the overall impression is anthropometrically wise child is normal. Then to summarize the case, 3-month-old female child born out of non-consanguineous marriage, second in birth order, resident of Lato, with complaints of white-colored stool since day of life 3, and yellowish discoloration of eyes and body since last 1 month, with adequate weight gain with normal development, and completely immunized, belonging to upper lower class, with no symptoms suggestive of liver cell failure, most probably neonatal cholestasis, and the differential diagnosis being first is biliary atresia, second polydocal cyst, third idiopathic neonatal hepatitis, fourth is hypothyroidism, then torch, sepsis, and inborn errors of metabolism.
Why most probably you still have doubt that it may not be neonatal cholestasis also? You still have doubts?
No, ma'am, I have no doubt.
So why most probably it is neonatal cholestasis?
Yes.
Yes.
Okay. So what you have to mention at this point that it is neonatal cholestasis syndrome. Most likely, which arm? Is it the hepatocellular arm or is it the biliary tract arm?
Ma'am, biliary tract, extrahepatic.
So most likely it is. Why you said that it is biliary tract and not hepatocellular?
Ma'am,
What are the
because
points that are not supporting it to be hepatocellular, and what are the points in favor of biliary tract?
Actually, the biggest point is that child has a persistent history of passing white colored stool. They like on history also the mother hasn't even once said his child has passed pigmented stool because during the course
Can
of
hepatocellular one cannot have clay color stool?
they can have, but there will be like transient episodes, but transiently there will be pigmented stools as well. So, but in
Okay, so this with clay color stool, you cannot say that it will
Baby,
always have transient in hepatocellular arm. It may have persistent clay color also.
and secondly,
baby is well thriving.
thriving, and there was
Yes,
no issue
If
vomiting
hepatocellular
also.
is there, so baby
yes,
is maybe
yes.
That is
sick.
Because that is
important.
the thing
That
that
is the
there will be
important.
failure to thrive, sick
Right.
baby will be there, all these things, preterm would be there. So you want to rule out first the obstructive causes, which would be biliary atresia colorectal cyst, and I would also like to rule out rest of the things so that the examiners show that at this point of time you are very sure about your differential.
Differentials.
Okay, you are in the right arm or the left arm. Okay, so you're because if suppose it was hepatocellular, what is the first investigation you will do if it is biliary tract or if it is the hepatocellular type? What is the first investigation you would like to do? You know that it is cholestasis, LFT will be deranged. It will be deranged, you know that. After that, what is the first investigation you will do in case of obstructive type of jaundice?
USG
Fasting
plus
US
Ultrasound abdomen.
fasting.
Fasting USG.
USG.
How many hours fasting?
4 hours fasting.
Yes. So at this point of time, examiner should know that you are very clear about your course of action. You are very clear that it is obstructive first and it may be hepatocellular also. Okay, at this point you cannot rule out. It may be hepatocellular also. Okay, had it been pigmented stool, then you'd have gone for hepatocellular first and some of the obstructive causes. Okay, in what condition? Suppose there is obstructive cause and stool is yellow. Suppose biliary atresia and the stool is yellow. Is it possible? Is it possible that a biliary atresia child will have yellow stool?
Partial, depending on degree of atresia.
No, there is no degree of
No.
atresia. Atresia is
No.
atresia. What is partial thing you are saying? Is there anything partial? Okay, we'll come to that later. A biliary atresia diagnosed child is having, mother is saying is passing yellow stool. You also saw it's yellow. Is it possible?
No, ma'am, not possible because pigmented stool there is rule out biliary tract pathology.
They may have yellow stool.
They may have pigmented stools.
How? They have yellow stool, not pigmented stool. They will have
They
yellow color
have. They
stool.
may have yellow stools.
How? I tell you that they will have. The stool will look yellow.
If it's ma'am like mixed with the urine,
Yes. And the urine is staining the diaper.
yes,
Why
ma'am,
will
totally.
not stain the stool?
Yes, ma'am.
And especially at 3 to 4 months of age. A biliary atresia child at 3 to 4 months of not earlier, they can present with yellow looking stool. What happens? There is staining of the epithelial cells, which are shut down,
Yeah.
and the stool is covered with the yellow
Yellow.
epithelium. So many a times you have to take the cross section of the stool.
So you
You'll
have to
find that
tell.
there is, yes, periphery is yellow and inside there is
Inside
clay
it is
color
pale.
stool.
So you have to tell the mother to always break the stool and see. And sometimes you have to wear gloves and break the stool by yourself to check because in rounds you cannot go wrong.
Yes. And if it is getting, you are sure that it is biliary atresia and it is a yellow color stool is there, then you have to separate the urine part and then
But
see if it is
second.
yellow or not. Okay. Okay. So at this point of time, you are sure that it is obstructive type of jaundice,
Yes,
right?
ma'am.
Yes, ma'am.
So we want to rule out or we want to, so your examination should be based on your differential diagnosis at this point of time, right? Okay.
On examination, child is active, playful, lying on the bed comfortably. Child is euthermic. Heart rate is 130 beats per minute. Respiratory rate is 34 breath per minute. BP is between 50th, around 50th centile. Saturation is 98% on room air. Capillary refilling time is less than 3 seconds. Central pulses and peripheral pulses is well felt. There is icterus present in eyes and all over the body. Then there is no pallor, cyanosis and clubbing there, ma'am.
Okay, so with this you are ruling out whether the child is sick or not on examination. अब तक
Yes,
तो
ma'am.
mother की history पे हम rely कर रहे थे. Now you're sure that child is not sick. Okay, so then somebody was telling me the classification sick and non-sick child.
Yes, ma'am.
Okay, so now you have to think about the all the differences in the non-sick child.
Yes, ma'am.
Okay? Yeah.
Ma'am, then
Dr. Surbi is muted by
Rupsa, can
the
you just
admin,
unmute
I
Yes,
think.
yes,
Surbi?
ma'am. I have requested her to unmute.
Yeah.
Got it.
ma'am, in head-to-toe examination, head shape is normal. AF is open at the level. No dysmorphic faces. Icter is present. No cataract or signs of micronutrient deficiency. Umbilical hernia is present. Mongolian spot on buttocks present. Genitals normal. Spine normal. No signs of acute liver failure and coagulopathy.
Okay, so head shape, can you give clarification for all these?
Ma'am, if is there microcephaly may be there, or macrocephaly may be there.
Okay,
Micro, more than macro.
micro more.
Micro.
Yeah.
Micro, more than macro.
AF,
Even in cases of
what is the significance of AF in cholestatic case?
Ma'am, AF bulgy, AF open. If hypothyroidism is there, wide AF open is there, then in intracranial bleed, AF is bulge.
Okay.
Yes. Okay.
even
Dysmorphic
ma'am, some
faces
syndromic associations, the like say Down syndrome, the occiput can be flat. So the head
and and
Alagille syndrome.
hypothyroidism. Ma'am said now, no, hypothyroidism will have dysmorphic faces, coarse faces.
Yes,
coarse
ma'am.
faces.
Allergen syndrome at 3 months of age. What do you are expecting? Gross changes so early? What is the facial features in allergy syndrome?
Broad forehead, pointed chin, then
Flat nose,
flat nose.
depressed nasal.
So, do these changes appear by 2 to 3 months of age? So, or they usually take time as the child develops? Allergens में इतना जल्दी तुम्हारे इतने facial features इतने जल्दी नहीं आएंगे. They will take some time to develop.
Yes, ma'am.
Okay, so how did you look for cataract?
Ma'am, by ophthalmoscope with and
You use ophthalmoscope, right?
yes, ma'am. In systemic examination, I will proceed with GI
What
system.
are the signs of acute liver failure? You have mentioned no signs of acute liver failure. What are the signs you have looked for in a
Ma'am,
3-month-old child?
ma'am, abdominal distension. If their abdominal distension is there, then dilated veins. If portal vein, dilated veins is there, then any bleeding, मतलब ecchymosis or then
Signs of hypoalbuminemia may also be present.
And palmar erythema. Sometimes in
Palmar
the
palmar.
footage
Yes,
that
ma'am.
it is a reddish flushed palm is there.
Yes.
Okay. Yeah.
When do they develop itching? Will a 3-month-old child develop pruritus? Cholestasis है, direct hyperbilirubinemia है. So when do they develop pruritus?
If the bilirubin level is more than 50, 15.
Age,
Age of
age,
the child.
age,
Age of the
age.
child.
Age mostly
When will they have
for
itching? Itching action.
Itching,
At what
itching
age
action
they'll
कब आ
have?
जाएगा?
Action.
for 5 months, around 5 months of age.
So how will you suppose the child? Uh, why is there pruritus? We're saying something. Why is there pruritus?
Ma'am, obstructive
Yeah, obstruction is there. Then what happens?
histamine release.
There is accumulation of that pigment in the skin, ma'am, which irritates.
Yeah, because of bile acids. Okay,
Acid.
so if the at 5 months the child was developed pruritic action. So how will the child manage before that? What will happen to the child? The child is having pruritus. He cannot itch also. What will he do?
Cry, inconsolable cry
Inconsolable
will be
cry.
there.
He'll be constantly irritable.
Yes,
Irritable.
ma'am.
Okay, and rubbing his mouth against
Mouth
his
and
mother.
in the first action he'll be developed, he'll be doing this.
This and pulling all these things. Okay, child looks very happy.
In systemic examination, I will proceed with GI gastrointestinal system, ma'am. On inspection, abdomen is protuberant, umbilical hernia is there, no dilated veins, scar mark, sinuses, no visible peristalsis, and genitals is normal. On palpation, no tenderness guarding rigidity present on superficial palpation. Liver palpable 4 centimeter below right costal margin. Liver span is around 7 centimeter, firm in consistency.
Liver span you have to mention in percussion, not palpation.
Yes, ma'am. Firm in consistency, border is round. Spleen is palpable around 3 centimeter. A 2.5 centimeter defect in the umbilicus, which is reducible with skin over the defect is hyperpigmented. On
Surface
purpose,
of the liver was smooth. Surface of the liver, feel.
Firm
yes,
surface.
ma'am. Smooth surface.
ठीक.
Yes. On percussion, tympanic note heard over the heard, and no signs of prefluid is there, ma'am. And liver span is 7 centimeter. On
Okay.
auscultation, bowel sound is present.
So at this time you should know the normal liver span. Okay.
Yes.
So what is the normal liver span?
Uh, for 6 to
The ma'am
7.
is saying that have only 40 minutes left. Okay.
Hmm.
Okay, we'll proceed with the game.
Yeah, we have time, but just wanted to tell you that we have that much time. So.
Now, in short, just know the liver span as per age. It is not the same for all ages, and
Yes.
it is very simple. When you just see the book, it is very simple for the age.
In cardiovascular system, no precordial bulge, ma'am, no visible pulsation. Apex bit palpable in fifth intercostal lateral to the mid clavicular line. S1 S2 heart, no murmur is there. In respiratory system,
Why do you want to know about cardiovascular system?
ma'am, if cholestatic jaundice associated with other congenital anomalies is there with
Like
cardiovascular,
which one?
Ma'am,
ma'am,
like in syndromic cases also, like AV fusion defects or VHDs can be there in Down syndrome. Even when we were talking
AV
about
cushion defect will present with cholestatic jaundice.
ma'am,
You
Down
are
syndrome.
seeing in the word.
Ma'am, Down
Relax.
syndrome,
You
hypothyroidism is associated with Down syndrome. So the Down syndrome can itself has
hypothyroidism
ma'am, Basson syndrome.
is
You.
Hassan syndrome is associated with congenital heart disease, ma'am.
associated with
Biliary
Down
atresia is
syndrome.
there.
Down syndrome will have heart disease, right?
ma'am. There are
Hello.
yes, ma'am. There's
Yeah,
ma'am, Down
Down
syndrome.
syndrome will have heart disease. Then a very important cause is Alagille syndrome.
Allegedly.
They'll have pulmonary stenosis.
Yes, ma'am.
Okay, so you want to rule out that.
Yes, ma'am.
Sometimes biliary atresia patient may have situs inversus also, and
Yes, ma'am.
you can pick that while you palpate, auscultate for heart.
Yes.
Okay, very rarely, but they can have that also.
Very,
So if there is no significant finding, you can just mention there's no significant finding or the cardiovascular
yes,
system
ma'am.
is normal. Instead of going for 3 lines and wasting your 1 minute, just say that cardiovascular system is normal. If the examiner asks you why do you want to know and why you're emphasizing on that, then you can come with these answers. Same is with respiratory system. If it is normal, just say it is normal. If they ask you for normal, what all things you looked for, then you'll have to go into
Yes,
detail.
ma'am. Yes, ma'am.
Okay, because we want to go to the examination and followed by investigation, followed by complete a case.
Yes, ma'am. In respiratory
Okay, so
system, it
you
is
are
within.
by this time you know there is a cholestatic case. You
Yes, ma'am. Respiratory system is within normal limit.
sorry,
Respiratory system is in normal limits. Normal.
is normal. Yeah.
In central nervous system, child is conscious, active, playful. All cranial nerves examination is normal. Tone normal, power normal. All superficial and deep reflexes normal. Neonatal reflexes are present.
So you can say no abnormality detected.
Yes, ma'am.
All central nervous system as per the examination is normal. Just finish it in 1 line. Yeah,
Yes,
you
ma'am.
have to take this, you have to write this all, what are all things you have written.
Yes,
Okay,
ma'am.
so you should be ready with your answer, but just to shorten it, just say that it's normal
Yes,
or
ma'am.
on examination.
Central nervous
Yeah.
system is within normal limit, ma'am. In summary, 3-month-old female child, baby of non-consensual marriage, second in birth order, resident of Latur with complaints of clay colored stools since day of life 3 and yellowish discoloration of eyes and body since last 1 month with adequate weight gain with developmental normal, incompletely immunized, belonging to upper lower class with icterus, umbilical hernia and splenomegaly with no signs of liver cell failure, mostly child is having neonatal cholestasis.
Why mostly he is
It
having
is.
neonatal cholestasis, right?
It is neonatal cholestasis.
Neonatal cholestasis, ma'am.
The child is having
Yes,
neonatal
ma'am.
cholestasis
Yes,
syndrome,
ma'am.
most likely obstructive disorder. It
Yes,
could be
ma'am.
my differentials are like this. However, I would also like to rule out other hepatocellular part also. Okay, so your
I would
first
not
diagnosis is obstructive. Yeah,
I
yeah.
would
So
not
you were saying something?
agree with like Madam said. I would also rule out the hepatocellular part, but I would not agree with congenital hypothyroidism because you have already said developmentally normal and no facial discrepancy. So don't get into it. You are well aware that it is not there. So just be like this is your conclusion. You have to say it with confidence that it is neonatal cholestasis, most likely obstructive biliary atresia choledochal cyst. However, I'd like to rule out the possibility of hepatocellular involvement.
Congenital hyperthyroidism as a cause of cholestasis is a very rare cause. Okay, so if you have ruled out everything, you are not finding any clue. Even you have ruled out genetics and you are not finding anything, then you go and look for hypothyroidism.
yes, yes,
Okay, so better not to mention it also. Okay, what you can
Yes,
mention is yes, idiopathic neonatal hepatitis, metabolic can present with this. Okay, and that's it. Yeah. Okay. So what will you do with this child?
okay.
What are the investigation you do?
Ma'am, we'll do basic investigation like CBC, complete blood count with LFTs.
Do you have the reports? Do you have the
Yes, ma'am.
reports?
Yes.
Sure.
Ma'am, if neonatal cholestasis is there, uh,
No, no. Do you
DNA
have the
पहले
actual
report.
reports?
Yes, ma'am.
yes, ma'am.
Reports हैं आपके
Ma'am,
पास?
Yes,
these
हाँ
are
ma'am.
the
मैम
Yes,
दिखाया
ma'am.
cases
था.
For the
that
investigation.
Okay.
so, ma'am, on time of admission, the complete blood count values were as follows. The hemoglobin was 10.2, the TLC
So why
10,500.
do you want to do complete blood count in a college child?
Ma'am, we actually did it to rule out any signs of infection. We can get a hint, like if the TLC count is raised or it's low. Even if the coagulopathy is there, matlab like then
Platelet
platelet
count.
count would be less. So that's why we did the CBC, ma'am. And also we could get a clue, like if child presented us to with jaundice, so like if the HB level was less, so we can think of like hemolysis going on. So
And also, if there is thrombocytosis, it will signify sepsis.
Yes,
sepsis.
ma'am.
Okay. Then what is the LFT?
This is the LFT. On time of admission, the total bilirubin was 4.8, with the direct component being 3.3. SGPT was 108, SGO2 was 230, and alkaline phosphatase was 804. And albumin was 3.45, and total protein was 6.
Which one is missing?
That's it, or do you have anything else also?
One is missing.
Ma'am, GGT?
Yes.
GGT, we have
in next slide.
this one, ma'am. The GGT value at time of admission was 249, which
Okay.
was higher than the reference range.
So reference range of GGT also changes as per the age group.
Yes, ma'am.
It is not required to know at your PG level, but just you should know that it changes. So if you get time or something, have a look. Otherwise, it is not required at your MD exit examinations. But INR is normal. So this was post vitamin K, pre vitamin K INR.
Ma'am, the INR that we did was, ma'am, 1.16, and
तो एडमिशन ऑन अराइवल किया था कि विटामिन के दे के किया था
on
कि
admission
एक ही
we have done.
एडमिशन एक ही वैल्यू है अपना.
Yes.
So with this report, what are the conditions you have ruled out that it cannot be these conditions?
Ma'am, sepsis part we have ruled out.
Okay.
Then hepatocellular causes rule out because GGT is raised.
No.
The LFTs were deranged, so hepatocellular causes could
There
not
are
be
some
ruled out
conditions in which GGT is normal or low. So you have ruled out that. What are those conditions?
You've said it before.
And you have mentioned that in your chart also, which you just showed. The flow chart is given there also in the corner.
And you mentioned it also. You've answered it. You know.
The flow chart you just showed, and we said that skip this. There is some note is there in the corner and very specifically mentioned. Though it's written GCT, it should be GGT, but it's written GCT wrongly.
Progressive
There are
familial.
yes, type 1 and 2.
1 and 2, yes, ma'am.
Okay, how many types are there?
Five types is there.
Total five types.
6 types are there.
6 types.
Okay, 6 types are there. So type 1, 2, and 4. They may have normal or low
GGT.
So with this GGT, you can rule out. Okay, suppose there is normal GGT. Okay, can it be 1 or 2, or it can be something else also? With normal GGT, in cholestatic case, GGT will be high. Okay, but suppose it is normal, so it could be 1 and 2.
Yes, ma'am.
Is there any other condition that there is a possibility that that condition also can be there with normal GGT? So biliary atresia may have normal GGT also. Okay, most of the times they have high GGT. So if the GGT is high, then you can rule out 1 and 2. But if GGT is normal, you cannot rule out biliary atresia. It still could be biliary atresia.
Yes.
So if your history wise and your there is clinical stool is there, then you have to still rule out biliary atresia with that. Okay, next. What you have more investigations?
Yes,
ma'am. We have the ultrasound, ma'am.
So you tell me, how do you get an ultrasound for biliary atresia done? How do you do it in your ward? Very simple answer.
First.
And what are the things you want to see on ultrasound?
Joe, what do you want to see? How you get it done? What are the instructions? And what are the instructions you give to the radiologist?
Pre-prandial and post-prandial we do, ma'am.
Good. Yes.
Then do the serologist to be like asked to specify certain signs, ma'am. Like there are signs, triangular cord
Triangular
sign,
cord sign.
or whether the gallbladder is collapsed or micro
Yes.
gallbladder. These are associated
These
with
kind.
biliary atresia.
और
And why do you want to do postprandial?
प्री एंड पोस्ट क्यों कर रहे हैं हम?
तो
Ma'am,
प्री में भी दिख जाएगा ना ये सब,
Ma'am,
तो पोस्ट क्यों किया?
if preprandial is in
Okay,
preprandial,
what happens why do you want fasting USG? Why
actually,
are you
after a meal,
emphasizing that
all
it should be
the
4-hour fasting? Yeah.
after a meal, like all the bile, normally what happens after a meal, all the bile will be like used up for digestion of that food. So the gallbladder
फाइल तो
will,
वैसे भी नहीं दिख रहा ना यूएसजी में.
ma'am,
ma'am, the gallbladder will
gallbladder
be empty
collapse.
because it will collapse, it will contract and release the bile. So when the child is like he has not eaten any food, so the accumulation of bile we can estimate. So due to the accumulation,
See,
gallbladder
after 4 hours of fasting, normally the gallbladder should be distended.
distended.
Okay, they have to mention this, and if you want them to mention this, you have to write that I want to see this.
You
So
should write.
preprandial, that gallbladder should be distended. This is normal. You can assess the size. Okay, size could be what is the normal gallbladder size?
Length. Length
Length.
mention कर.
3 to 4 mm.
2 to 4 mm. 15 to 19 mm. Okay.
1.9 centimeters का कट ऑफ लेते हैं अपन.
So if it is small gallbladder or atretic gallbladder or gallbladder is not seen, then it goes in favor of biliary atresia. Okay. Then why we want postprandial? Because postprandially, as Dr. Shivanjan was saying, that bile comes out. Okay, the gallbladder contracts. Okay, if there is poor contractility, which means that less than 60% contraction is there, that they will assess by the size, preprandial size and postprandial size. If the contraction is less than 60%, that means there is poor contractility. So even in a normal gallbladder size, if there is poor contractility, it goes in favor of biliary atresia. So only normal gallbladder will not rule out biliary atresia. Okay. So sometimes there is fasting only done. Gallbladder size is 18 mm normal. But if you haven't seen the contraction, then it is incomplete. Okay, so what you have to see, preprandial size and postprandial size, whether gallbladder is absent or not, atretic or not, and also one more thing you have to see. What is that? In USG, you have to mention that. If you don't mention, they will not see it. What do you want to see?
Paucity of biliary ready.
No, positive will be not seen in ultrasound. That is a biopsy diagnosis.
Biopsy diagnosis.
You have to ask for the size of CBD. Okay, common bile duct. If it is
CBD
smaller or if it is dilated. Okay, if it is dilated, it goes in favor of what? Choledochal cyst. Okay. If it is contractile or atretic, then it goes in favor of biliary atresia. What else they will mention? They can mention in ultrasound that can give you a clue about cholestatic child. What else you will see? You will look for biliary atresia, all these signs. You will see for choledochal cyst. Okay. But suppose choledochal cyst is not seen. Sometimes it is not seen. Okay. What is one thing that will tell you whether it is choledochal cyst or not, which can be picked up on ultrasound? Dilatation of intrahepatic biliary radicals. They normally write it. It is there in their protocol that intrahepatic biliary radicals are not dilated or dilated. If it is dilated, then to some extent it rules out biliary atresia and goes in favor of choledochal cyst. So the next thing you need to do is MRCP. Dr. Rajat, can you mute yourself?
So basically on USG, pre-feed, post-feed, they need to mention contractibility, they need to mention size, they need to mention CVD, whether intrahepatic dilatation. Sometimes they can also mention the epithelium of gallbladder if some senior is doing the USG. Then they do need to mention liver, the liver echo texture. splenic, and if any splenic malformation, and they need to comment on the bilateral kidneys as well.
So like in this ultrasound, they have rightly mentioned that GB appears atrophic, measuring 1.5 mm, which is to some extent normal length.
Normal.
But size remains same even after 2 hours. What's that? NBM?
It is NBM.
NBM.
Okay. No, it should be like postprandial, ideally, that the size remains same because there was no contraction. Okay, atretic biliary radicals they have seen. Okay, triangular cord sign also
Cord
they have
sign is
seen.
visible.
So that is 95% biliary atresia. If the sonologist is very experienced one, then it is 100% biliary atresia if they have actually seen the triangular cord sign. Have they disappeared?
Ma'am, in the above report, it's also mentioned about the CBD, the common bile duct size. It's 2.2
Yes.
mm normal for age. So
Yes.
can it be there with?
Yes, it can be there. It could be anything. Only atretic gallbladder can be there. CBD will be normal. Normal size gallbladder will be there on fasting. CBD will be normal, but there will be poor contractility. Okay, so you have to see completely. If any of these things are there, it's not possible that everything will be there. If the whole biliary tree atretic, I think they have mentioned that something atretic biliary radicals, triangular cord sign is there, thickened echogenic measure. Triangular cord sign is there. Okay, so gallbladder size is normal. They have not seen the contractility. Most probably, they should be having poor contractility. So anything is there, it goes in favor. If in a child who is cholestatic, gallbladder is atretic or CBD is atretic, or then it is 95% biliary atresia. You just have to subject him to surgery if the age permits. Okay, but if there is a doubt, suppose they say that gallbladder size is normal, CBD is also normal, which is a possibility. In 20% of biliary atresia patient, they can have normal biliary tree. So in that case, you'll have to go to the next step. Okay. So at 3 months, child has come with you with query biliary atresia. Suppose triangular cord sign was not there. They have not seen, and there is atretic biliary radicals or small size of gallbladder is there. So at 3 months, what will you do? What are your options for this child? What investigations or what steps you will take?
Ma'am, we can go for the another screening test. HIDA scan. We can.
See, why do you want to do HIDA now?
HIDA
What will HIDA scan tell you?
What is seen in HIDA scan? Shivanjan?
Ma'am, the radiolabel, the dye that we give. So we see that the passage of dye, like from the point it has been uptake from the liver and it passes through the biliary system to the intestine. So that we see. So it tells us like whether there is a continuation of flow.
So it proves that there is no biliary atresia.
Atresia.
तुझा dye दिख गई. But we need to do a test to prove that it is a biliary atresia.
Ma'am, we'll do liver biopsy or in.
So see, what is Kasai surgery? Have you heard of that?
Yes, ma'am.
What is that? And what is the right time to do it?
Ma'am, around 29 to 60 days, 1 month to 2 months.
Less than 8 weeks.
Why 29, 30?
1 month to.
Ma'am, child should be operated before 8 weeks, actually.
Before 60 days.
Before 60
or
days.
90 days. Okay. So as soon as you do it, the drainage is established. Okay. So the child is coming to at 3 months. Already he is 90 days old.
Oh.
And now you are going to go for liver biopsy. How many days the liver biopsy will take?
Ma'am, 2-3 days. 2 days.
Ma'am, it comes in 2-3 days?
Yes.
Okay. So,
but
with this picture, when you are 95% sure that the child is having biliary atresia, okay, atretic biliary atresia, triangular cord sign is there. Why waste time in liver biopsy? Suppose liver biopsy comes non-specific. Will you rule out biliary atresia? No. So it is of no use now at this point of time in this particular baby. So the right thing to do in this particular baby who comes after 3 months or around 3 months of time to save time, because we don't want to delay more.
Yes,
The
ma'am.
best thing is to do
IOC.
IOC. What is IOC?
Cholangiogram.
What is IOC? Sorry?
Intraoperative cholangiogram.
Yeah. So what do they do in that?
Ma'am,
They will open the abdomen, they'll inject the dye and see whether it is actually biliary atresia or not, and take liver biopsy. If it is biliary atresia, they'll do Kasai procedure. If it is not, they'll close. Okay. Suppose the child comes at 2 months of age. Then, if you are not sure that it is biliary atresia, even at 2 months of age, if the child comes with you with cholestasis, clay color stool is there, and gallbladder is atretic or CBD is atretic, then also you can skip liver biopsy. You can straight away subject to IOC and confirm. But if there is any suspicion that it may not be biliary atresia, then you can go for liver biopsy. Okay, so liver biopsy will confirm, most of the times confirm that it is biliary atresia, and then you can subject them to surgery, because at 2 months there are very less surgery. You would be convinced that only on the basis of investigations you have diagnosed, and without liver biopsy you have diagnosed that it is biliary atresia. So they want a definite diagnosis, then you have to go for liver biopsy. Suppose your child comes at 1 month of age. The child comes at 1 month of age with small gallbladder, with cholestasis and small gallbladder. What will he do? There are only three things remaining: HIDA, liver biopsy, and IOC. Okay. At 1 month of age, child comes with this picture and gallbladder is small, or poor contractility of gallbladder is there, which to some extent favor biliary atresia. So what will be your next step?
ma'am will go for liver biopsy in that case.
So at
So
one,
this left-
1 month of age, you may not get the real picture of biliary atresia. It may come non-specific or may come normal also.
Non-specific.
Non-specific. Okay, they'll say that certain changes are there which will not help you to diagnose biliary atresia.
Biliary atresia.
So what will you do? So there comes the role of HIDA scan.
Yes.
Okay, suppose at 1 month of age, child presents to you with cholestasis. You are not sure, you cannot send the patient directly to surgery. There's no point in doing, or not much benefit in doing, liver biopsy at this time. So if you get HIDA done at that time and the HIDA is draining, it will rule out biliary atresia. Okay, so HIDA helps in only one thing. It cannot confirm biliary
Ruling
atresia.
out.
It will only rule out biliary
Only
atresia.
rule out biliary atresia.
So at 1 month of age, if you are ruled out biliary atresia, you are relaxed. Okay, this could be hepatocellular thing. It could be IV infection also. It may subside in coming 1 or 2 weeks. You can follow up the child after 1 or 2 weeks and get the LFT done. If it is on the decreasing trend, well and good. If it is not, you can still wait for some more days and then do liver biopsy, which will give you a real picture. Okay, so you have to decide after on clinical your history
Judgment.
on examination. You have to decide it is hepatocellular or obstructive, and these investigations will give you more clues whether this is biliary atresia or not. You have to, in any child, you have to rule out biliary atresia. Okay, because if we subject them to surgery before 60 to 90 days, they will have benefits. Okay, so first thing is that you have to think about whether it could be biliary atresia or not. If it is pigmented stool, you don't need to do HIDA scan. It is a physiological HIDA. If it is, you are sure that the stools are pigmented, it is not biliary atresia. Okay, so you can go for other causes. So depending on the age of the child and depending on your investigations up to ultrasonography, you have to decide what do I need to do with the child. Whether I need to do HIDA, whether I need to do liver biopsy, will it save time or not, or will it waste our time, or directly subject the child to IOC. Okay. Do you have any other, did this child was subjected to surgery?
What came?
Actually, we did a pediatric surgery reference, so they advised liver biopsy for this child first. So we did the liver biopsy for this child, Ma'am, before that we did the HIDA scan as well. So
So HIDA was
this is the HIDA scan, ma'am. So the findings were like they showed high probability of biliary atresia. So after the delayed phase, also after 24 hours, also the dye did not like came to the yes
Pass into the duodenum.
duodenum. So this was the biopsy report, ma'am, which was suggestive of biliary atresia with the fibrosis score 3.
so you could have convinced the surgeon with your knowledge that I don't want to do HIDA scan. There's no point in doing HIDA scan now.
So,
Okay.
ma'am, actually,
That
the point is some surgeons, even in private practice, do not proceed with the
without HIDA.
Kasai photointerostomy without HIDA scan. Although we have tried, even in Bombay, we've tried it multiple times, like it is proven, but they do want a HIDA scan before, even in proven cases of biliary atresia. So that is one thing which is lacking, or I don't have the exact word, it's not lacking or something, but yeah, they don't, this kind of don't
Yeah,
proceed with.
here they do it without the
Yes.
HIDA or liver biopsy. At 3 months of age, even a 100 days patient, I have subjected them to surgery without HIDA and liver
Yes,
biopsy.
ma'am, but
Why do you
kind
want
of
to have liver biopsy? Even it is confirmed biliary atresia on IOC, the surgeons take liver biopsy. Why?
yes, which
Why do they take liver biopsy? What is the use of liver biopsy now? When it is, see, IOC is the gold standard for diagnosis of biliary atresia, right? So they have done the gold standard. They have confirmed that it is biliary atresia. They have done Kasai surgery also, but they are still taking liver biopsy. Why? So there is something called ductal plate malformation, okay, which is seen in biliary atresia. So if the biliary atresia is because of this particular abnormality, ductal plate malformation, then the Kasai is not going to be successful. Okay, so with if they have this diagnosis in their hand, they can prognosticate that this is not going to be a good success. The success rate in ductal plate malformation is very low. Okay, so they have to take the liver biopsy at the time of surgery. Okay. So is it the definitive treatment, Kasai surgery?
No, ma'am, liver transplant. Matlab, the liver transplant is, ma'am, the
All
definite.
biliary atresia patient who had Kasai will require liver transplant.
Ma'am, depends on the extent of like fibrosis that has been subjected because of the.
So, what are the prerequisites for success of Kasai, and what is the proof that the Kasai is successful or not? What are the prerequisites
Ma'am,
that Kasai will be successful?
if age of the babies between 1 month to 2 months is there, as early as possible we will do Kasai surgery. The prognosis of the baby will decide on that only.
And
And uh, uh, good surgeon.
yes, and in the
surgery के
baby,
बाद surgery के बाद
and one more thing in the baby, which will decide whether it is going to be successful or not. Whether the child has already decompensated or not, whether the
not
cirrhosis has started or not.
not
Yes, ma'am.
Cirrhosis can start anytime. So, if 3 months of age, if there is cirrhosis there, well, so what they have written,
Ishaq fibrosis score 3.
yeah, fibrosis score 3 is there. Okay, so with this, the success rate goes little down. Okay, so this will decide that so they can, before for medical legal purpose also, you can tell the patient that with this already cirrhosis, this much maybe the success may not be that much what we are expecting. Okay, so post Kasai, whether it is successful or not, how will you decide?
Ma'am, if yellow discoloration is decreases or clay color stool improving color
How
of the
long you
skin.
will wait? How long you will wait? Okay, the mother says that there is no jaundice. Jaundice is not seen. You called her up. She said no, there is no jaundice. So will you be sure that it is successful?
No,
So total bilirubin should be less than 2.
Yes.
After
after the
when?
How much time after surgery,
How much
madam is
time wait?
asking?
Ma'am, 2 weeks.
3 months. So after 3 months, if the total bilirubin is less than 2, then it is a successful Kasai. And when is jaundice seen in eyes? When the mother can notice that there is icterus, what is the level?
More than 5.
More than 3. Okay, 3 to 4 they can notice. So if it is 2, mother will say that there is no jaundice. 2.53 is also there. She might say that there is no jaundice, but it may not be a successful Kasai. Okay.
Yes, ma'am.
So how is the child doing? Okay, they did Kasai after that in
No,
this
ma'am.
baby.
The child
Why?
is tested for surgery. Still, as of
Acha.
now, surgery is not in question. But they will take the child like day after tomorrow.
Okay.
Okay.
Yes, ma'am.
मतलब होने वाला है ना कसाई
One
होने
Yeah.
वाला
person. Yes, ma'am.
So how old is the child now?
है. Days.
Tomorrow, how many days it be?
How many days?
Ma'am, it's been 12 days since the child was admitted with us. So the current age is 3 months, 12 days.
Okay, 102 days.
102 days. Yes.
ठीक है.
Okay.
And do they perform IOC, madam? In
They
civil
will
line?
they will do it. They also take a biopsy again in the
नहीं
instance
नहीं
all
ma'am,
the
for
surgery.
diagnosis ma'am, if like this in only
In
for
I think that
diagnosis.
is standard
no,
protocol they do
yeah,
before
they
Kasai. All of
will.
them do IOC.
नहीं मैम वो तो होता ही है.
हाँ.
Before surgery तो
Yeah,
IOC is there for the diagnosis case, not before surgery. Sometimes like as we do, like
For
there
diagnosis,
is,
do they do? You are asking. Okay.
yeah, before
they,
surgery
No, if they
IOC
are
is
not
done.
opening without HIDA and biopsy, they will not go for
no,
diagnosis
they
also.
are not doing it.
They'll
They are
ask
not
for HIDA and then biopsy first, and then
biopsy
they'll
first.
open.
Yes.
I'll have to talk with them now
Yes, ma'am, definitely. This
after this
patient did
case
not
study.
require HIDA and biopsy. Definitely not HIDA. Okay, biopsy to some extent I'll agree, but HIDA was like it will not.
Biopsy, what they can do is they can do intraoperative
Yes, ma'am.
biopsy. They have the cryo facility which is there in the pathology department. The only thing we have to channelize that, that they have the
Yes, ma'am.
confidence of opening up very quickly. They give the reports.
Yes.
If the
They
ma'am
can do.
if they mentioned triangular cord sign is there, gallbladder small size, even biopsy was not required pre-op. Directly subject the child to IOC. And
They have,
with
yes.
this
They have to
investigation,
trust the
yes, ma'am.
ultrasonologist.
Yes.
Okay, but the report was quite good. It was
Good.
in detail,
Yes,
quite
ma'am.
detailed.
Yes, USG
Yes.
was very good, ma'am. Yes, ma'am. To the detail.
Okay, so anything else, Shivanjan Datta?
Uh,
Yeah, I should
Okay,
say
you both of you presented really well.
Thank you.
Thank you,
Thank you so
ma'am.
much.
you can stop sharing then.
Yes. Ma'am, the last slide, of course.
You want to
This is
thank you also?
yes,
Okay,
this is
all
the slide.
right. Yeah, we
Sweet
need
girl.
to thank
Best wishes
both.
to the baby.
Yeah, we'll see what
Very playful,
happens
ma'am.
now.
Very playful.
Hmm. They are playful actually, and
This is
it's very
the
sad that we are most of the time not able to do
not able.
Do much
anything for
more.
them. And it's I think the youngsters should know that the normal age for biliary atresia presentation, even in West, is 3.5 months, 3 to 3.5 months. So most of the times the time is not there. Okay, so if you are aware, and I'm sure that this child must have gone through many pediatricians, and they must have noticed that the child is having jaundice, and they didn't do anything, or they must have told that it is physiological, it will go away. Most of the time, this happens, especially when they are less than 14 days of age.
Ma'am,
So they think that
actually,
okay, it will go away, and then they don't come for follow up.
ma'am, the mother
They
actually
didn't go for the
ignored the
vaccination also.
Yeah.
Yeah.
mother
Sorry.
mother actually ignored the symptom of that white colored stool. She thought that like child is feeding well and it's fine. So the
But we
parents
cannot blame the mother, right? Yeah, we cannot blame the mother at this point because she's not aware that clay color stool is pathological. But
Pathological.
if somebody has seen at day 6 weeks, she went to some health worker.
health
If
organ.
you would have known that okay, this jaundice is not, I mean, we should work up the child whether it is conjugated or unconjugated, then we could have had better results with this child.
Yes.
So, yeah, even ma'am, I've seen that those NICU graduates who come after 2 3 months of for follow up, they have this cholecystic jaundice. But most of the time, it is self-limiting; it subsides. But
Uh-huh.
yeah, for all NICU graduates
It's
who come
not
from there,
related to biliary problems. It is just
it is
the
because of
part of
sepsis, ma'am. Yeah,
sepsis.
Sepsis.
All
but
right. So
they should, these patients also, we should rule out biliary. It is a simple ultrasound will give you the diagnosis whether it is biliary. And most of the times, if you get a good ultrasound, you'll get can rule out or rule in or suspect biliary atresia.
all right. There is one question from Rajat. Shivanjan, can you answer it? It is the what calculation we do for proteins and calories of breastfed baby. Okay, 500 ml.
Yes,
That
ma'am.
calculation he wants.
So actually, the amount that we consider is like between 400 to 600 ml. Uh, uh, so accordingly, we know that per 100 ml the calorie of like breast milk is around 65 to 70 kilocalories. So we have taken that and we have multiplied it by 5 or 6, the maximum amount, like 600 ml. So 67 into 6. That is for the total amount produced per day. The calorie will be there, the calorie amount. And for the protein also, we have done the same thing. It's like zero point 0.9 to 1.1 gram per deciliter. It's the protein per 100 ml. So we have calculated the protein requirement accordingly, ma'am. So for 600 ml, we have considered total output, considering the normal values, and then we have calculated.
So, Rajat, this is an assumption that the mother would be producing around 600 ml of milk in 24 hours. And then all your books mention 100 ml of breast milk of a term for a term baby will give so many calories and so many proteins per 100 ml. So that's how you will calculate that 500 or 600. She may feed it 6 feeds or 8 feeds, but you are calculating for 24. Okay, sometimes they ask you, especially when you're having a case in a neonate or you are having a failure to thrive case in either. Okay, so I think we have, our time has just flown. It is almost 2 hours. Okay, so first let me thank Dr. Rimjim and Dr. Surabhi. I think I have learned many new things today from both of you. So that is the advantage of having experts in these fields because many things we do without the advances. I'm sure Shivanjan, Datta, and Sangeeta, who has mentored them, she's our assistant professor. So I should congratulate all three of you for a really good presentation and a very good discussion. Many new things have come out of it. I think our practices also we could change. I have to go and talk with the pediatric surgeons and also thank these radiologists because first time I saw a very good report. So if all
Yes, ma'am.
reports come like this, maybe our surgeons, Dasmeet is there. I will have a chat with him. But he does take up patients and he had told us that he just needs it for counseling and for the medical legal purpose because the parents think that after surgery child is going to be absolutely normal.
Yeah.
When they do counseling pre and post surgery they always say ki 60% or 50% chances child will recover, but we have seen babies coming late, and one of the things which we can concentrate now is also the immunization center and also teach our nurses to pick up that. Many times it is passed off as physiological and that is delaying the diagnosis. So I'll really thank both of you and all those who have joined. And I think if you want to do a presentation, Rimjim, quickly
Yes, ma'am.
for
This time
media.
I can do, ma'am.
Yes, yeah. Rupsa, do we have time? Ankita's, I think Ankita. I think you can start it. If we are overshooting, they'll ask us to stop.
Yes, ma'am. I'll just
Yes,
share
Okay.
my
ma'am.
screen.
Yeah. Can you share the screen then, Rimjit?
Uh, Ma'am, if I am sharing it from my end, so then I need Uh, will
No, I
ma'am
am
be able
sharing.
to? Okay,
No,
Yeah,
okay,
yeah.
Dr. Rimjim is sharing.
okay,
Please
okay.
allow her to do it. It's a
Is
short
it?
presentation. It will be a
Yes,
recap of all the things we have discussed.
yes, it is shared, ma'am. Just make it full
Yes.
screen. It is perfectly sharing.
Okay. All right.
Is it visible?
Yes, ma'am.
Yes,
Perfect.
please. Thank you.
Okay, so the case was very good. So we'll see some few cases. I've already discussed this. I'd like them to answer. So this is a 1.5-month-old male child, full-term normal vaginal delivery. Icterus was there and high color urine was there since last 15 days. Vitals were stable. Child was well with mild icterus. Per abdominally, there was hepatosplenomegaly. LFT was deranged. GGT was 173. So clearly, what is the diagnosis at this point?
Colas,
Neonatal cholestasis.
obstructive jaundice.
Of
Uh, okay, so before saying that is obstructive jaundice, you have to say that this is neonatal cholestasis
Cholestasis.
syndrome,
Yes.
and then you have to classify whether it is obstructive or hepatocellular type.
Yes.
Okay, so neonatal cholestasis is a very important cause of chronic liver disease. Still is called chronic liver disease, even if the child presents at day 10 of life or in the first week of life. And almost two-thirds of chronic liver disease is because of neonatal cholestasis. Okay, so it indicates hepatobiliary dysfunction. So if a child comes to you with cholestasis, that is with jaundice, clay color stool, it is neonatal cholestasis, no doubt. You don't have to think anything else. You have to decide and differentiate between the causes of it. So, what is actually cholestasis? So, you should be aware of this biliary tree. Okay, this picture should be there in the mind. What happens? Bile is produced in the bile ductules, which passes from right and left hepatic duct to common hepatic duct, then goes to gallbladder. Then from there, cystic duct is there, and they both combine to form common bile duct, and that drains into the second part of the duodenum. Okay, so for any reason, if there is obstruction to the normal excretion of the bile, if the bile is not flowing normally, this is the normal route which should be there. If there is obstruction to the normal excretion of bile. Now, why there will be obstruction? There could be two causes. One, there is actual mechanical obstruction which is seen in biliary atresia or choledochal cyst, or there is something called paucity of intrahepatic bile ductules, where there is less number of bile ductules. So the flow is not proper. Okay, so there is stasis of bile that leads to jaundice and other symptoms. Second thing is that when there is transport defect is there, bile, the biliary structure is normal, but the transporters for bile are not normal. There is mutation in the transport proteins. In that case, what will happen? There will not be a normal bile flow, and there again will be stasis, and that will lead to jaundice and other complications. So, how do we define conjugated hyperbilirubinemia? That is direct bilirubin more than 1 gram percent if total serum bilirubin is less than 5, or if it is more than 15% of total bilirubin if total serum bilirubin is more than 5. So you have to calculate most of the times. So the definition given in our books is that prolonged elevation of conjugated bilirubin beyond 14 days of life is called cholestatic jaundice. But this 14 days was, as I said, that it was given for field workers, so that physiological jaundice is by the time is resolved, and then they notice it after that and they refer the patient. But this does not mean that if the child comes to you in first week of life, you should not diagnose it at cholestatic jaundice. So any age, if the child is presenting with conjugated jaundice, it is pathological and you need to work the child. So conjugated hyperbilirubinemia occurring in the newborn as a consequence of diminished bile flow should be the definition of neonatal cholestasis, not the duration wise. So conjugated hyperbilirubinemia at any age in a newborn is pathological and it requires evaluation. So that you should keep in mind. Now this child presented at 6 weeks for immunization and he still had jaundice, but he was not investigated. So this is the two arms which I was talking about. That one is biliary arm, which is seen in almost 55%, and that is the obstructive arm. So in this, you will find structural anomalies or obstruction is there. The differential could be biliary atresia, choledochal cyst, gallstones, or biliary sludge, very rare. Alagille syndrome, which is also part of paucity of intrahepatic bile duct. There is paucity, there is less number of bile ducts are there, so the flow is not normal. and inspissated bile syndrome, which is a rare condition where because of many risk factors like drugs or hemolytic anemia, infection, there is sludge formation in the biliary tree that leads to obstruction. Other arm is the hepatocellular, where there is impairment in the bile transport. The biliary tree is normal, but the transport proteins are defective. Or genetic or metabolic abnormalities and intrauterine or other postnatal infections also can lead to this type of picture. So, idiopathic neonatal hepatitis. Now, this idiopathic neonatal hepatitis is a very, very broad term. So it means that there is some reason, but we are not able to find out what the reason is. So nowadays, because of the advent of the genetic testing, the percentage of idiopathic neonatal hepatitis is going very down because more and more cases we are picking up more and more metabolic and genetic conditions which are associated with neonatal cholestasis. So viral infection, bacterial infection, and genetic metabolic disorders are what we come under hepatocellular harm. So how will they present? They can present with jaundice as this child presented, or they can present with acute liver failure directly. So what are the condition in which in a newborn, if the child presents with cholestasis and acute liver failure? So there are very few. One is neonatal hemochromatosis, another one is tyrosinemia, and in some patients of galactosemia, you'll find acute liver failure. Bleeding from manifestation, they can present, they went for immunization and the bleeding was not stopping, or pruritus also, especially more than 4 to 5 months of age children, they'll have itching, or less than that, they'll have irritability. India, biliary atresia is the most common cause for obstructive jaundice, and infections and idiopathic type is for hepatocellular cause. So in color stool jaundice, the first thing you need to do is to rule out biliary atresia, and that is by a simple proper ultrasonography. So, as I said, the mean age of presentation for biliary atresia to a tertiary care center where surgery can be done is almost 2.8 to 3.9 months. And by the time all investigations are done, most of them cross the limit of surgery. And most of the time, surgeons say that we don't want to touch the child because child is above 100 days. But some centers, they have done operated children at 100 or 120 days also with good results. So it's very important that we pick these children earlier and subject them to surgery. So the goal is to completely do the diagnostic evaluation and or at least exclude biliary atresia by 45 to 60 days of life. That I was talking about, that if the child comes to at 1 month of age and you are suspecting biliary atresia, that time you can do a HIDA scan and rule out that it is not biliary atresia. If it is coming draining, if it is not draining, then you are in a fix, then you have to work the child up and rule out biliary atresia. So history, all these things you have taken very nicely, everything you have covered. So this is a stool chart, which you can use. So 1, 2, 3 is abnormal. So you can see that third one, most of the mothers perceive it as yellow color stool. So it is very important that you see the color of the stool with your own eyes for 3 days, then only decide whether it's clay color or not. So these are the investigation, LFT, TGT, you have to do. INR is very important to do, and ultrasonography after 4 hours of fasting. INR has said that acute liver failure is more than 1.5 with encephalopathy, and this is after vitamin K. So in the first instance, you don't have to label the child with more than 1.5 as acute liver failure. You have to give vitamin K, wait for 6 to 8 hours, repeat the INR, and if at this point of time it is more than 1.5 with encephalopathy or more than 2 without encephalopathy, then it can be taken as acute liver failure. In newborns less than 1 to 2 weeks, some say that you can take INR as more than 3 also. If it is more than 4 at any point of time, then you have to prepare the child for liver transplant. Because if it is rising, then without liver transplant, the child is not going to survive. So,
Um,
on ultrasound, we already discussed that these things you have to see for biliary atresia. If the common bile duct is if more than 2.3 normal size or atretic, if there is triangular cord sign is there, if there is absent or small GV with poor contractility, then you have to suspect biliary atresia. Other things which you can pick on ultrasound is political cysts, gallstones, rarely seen in this age group, and sludge. So this is a 75 days old child with full-term normal vaginal delivery. Cholestatic jaundice is there, and ultrasound was normal. Non-fasting was within normal limit. What was the next step you do? Dr. Shivanjan, are you there?
Yes, ma'am.
Yeah. What is the next step you will do? Ultrasound is normal. With cholestasis there, and ultrasound is normal.
Intraoperative cholangiogram.
So this
But
ultrasound is
we can go for
non-fasting.
directly for liver biopsy, ma'am.
No, this is non-fasting ultrasound.
Non-fasting, na?
You
Achha,
have to get 1 4-hour fasting ultrasound.
Yes, ma'am.
Most of the time, the child comes from outside. They have ultrasound report, which is most of the times is non-fasting. So you have to now this in this child the cholestasis was there, and when we did 4-hour fasting, the child was having small non-contractile gallbladder. Okay, so this is very important. Later on, the child turned out to be biliary atresia. So, if the ultrasound is non-fasting in a cholestatic child, it is giving you incomplete information. You have to have a fasting ultrasound, and you mention in the request form that you want a preprandial followed by postprandial ultrasound for gallbladder contractility. You have to mention this, otherwise they will not do this. So HIDA scan, as we were discussing, that HIDA, you already mentioned what is done in HIDA, but it is only that it will only rule out biliary atresia. If the HIDA is not draining, that does not mean that it is biliary atresia. It simply says that there is obstruction, which this obstruction could be because of biliary atresia or could be because of other causes also. But if there is draining HIDA, excreting HIDA is there, then biliary atresia is ruled out. So in this 1-month-old child, cholestasis and after 4-hour fasting, gallbladder was small and contractile. What will you do in this case now? Now the fasting ultrasound is saying GB is small and contractile. So in this case, we can do HIDA because in 1 month, liver biopsy is not going to give you the true picture. Maybe non-specific also. If it now in this child it was excretory, so there are chances that it will be because of some hepatocellular or intrauterine infection causes. So in this child we can wait. We are not in a hurry because if INR is normal, child is stable, then we can wait for 1 or 2 weeks and then decide whether the LFT is on decreasing trend or not. If it is decreasing, that means most likely it is because of IU infection, and you can wait further or decide later on also. So, where does liver biopsy help? So, liver biopsy will help if it is biliary atresia or there is something called paucity of intrahepatic bile ducts or some metabolic and storage disorder. They can give you some clue that it could be some this metabolic disorder or PFIC and in something called neonatal sclerosing cholangitis. So, only in these conditions, liver biopsy can be helpful, but in most of the metabolic and storage disorder, it becomes non-specific, and then you have to resort to genetic workup. So this is a 5-month-old child, full-term normal vaginal delivery with neonatal cholestasis, and presented with subdural hematoma with convergence on day 21, most probably because of intracranial hemorrhage. Ultrasound was showing gallbladder normal, hepatomegaly with post-echo texture. Now what will you do? At 5 months, what will you do?
ma'am,
INR is 1.3.
Yeah, INA is 1.3.
The subdural
Maybe
hematoma
after correction.
correction.
Yeah, the history of subdural before coming to the hospital, he had hematoma.
Okay.
So
Liver.
5 months, what will you do?
ma'am,
Under FFP cover, we can do IOC.
IOC only, or will subject the child for liver
See, at
transplant.
5 months, no surgeon is going to touch the child because the prognosis is very poor at 5 months of age. So what you can do is do liver biopsy. Even if it is biliary atresia, just you have to counsel the parents and prepare them for liver transplant. Okay, at 5 months, you are not going to go for surgery. They have to either go for liver transplant. If they are not affording, then sadly you can't do anything. So this child turned out to be PFIC. PFIC, so liver biopsy will not give a clear-cut picture, but on the basis of the features, we decided that it is PFIC. and the child is doing well after that actually. Had it been a biliary atresia, he would have decompensated. So at 5 months,
was not done, madam.
yes, yeah,
Genetics.
generally they were not ready for genetics actually. So on the liver biopsy only we thought that okay, we'll follow up the child and the child is okay. So 5 months, don't think about surgery. No surgeon will do. You just have to do liver biopsy, confirm the diagnosis if you can, or you can go for genetic testing. Now the genetic testing is very costly, so most of them don't afford that. But if you can get genetic tests done, that is well and good. You can have a diagnosis, and on the basis of diagnosis, you can prognosticate the child. Now this is 98 days old child, again with cholestasis. Ultrasound gallbladder was normal and CBD was cord-like. Okay, gallbladder was normal, but CBD was cord-like. Now what will you do in this case? 98 days.
Ma'am, directly
Yes.
intra-operative
So
cholangioscopy.
in this child, directly IUC is preferable, and this child turned out to be biliary. Surgeon agreed that okay, this picture is cholestatic and could be biliary, so agreed to open the child directly, and he was biliary. Now this is 120 days old child again with cholestasis. Ultrasound was normal, post echo texture was there, liver biopsy was done, and it was non-specific. Now what will you do? The parents want a diagnosis. They want to know what is happening with their child. So this at this point of time, you can resort to genetic testing, and this child turned out to be mitochondrial gene deletion syndrome, which is a very rare condition and very fatal condition, and the only treatment is liver transplant. So just come to the flow chart which you were saying showing. So in this, this is a 2014 guideline, and you have to differentiate on the basis of history whether the child fits into the obstructive part or the hepatocellular part. What will decide that whether the child is sick or non-sick? If the child is non-sick, pale stool is there, then you have to think of biliary atresia. Try to rule out biliary atresia by ultrasonography. If it is possible to suspect that it is biliary atresia, then subject them to IOC depending on the age. Or if the surgeons are not convinced, then you can go for liver biopsy and then go for surgery. Again, in pigmented stool, they can have, and the child may not be sick in this part also. That is the PFIC. Okay, especially type 3. So they are not sick. Type 1 and 2 are little fatal. They will be sick at times. But type 3 is not fatal, and as you said, that we can decide that on the basis of GGT. So if it is normal, it could be 1, 2, and 4 also. If it is raised, then it could be the rest of the PFIC. And if the child is sick, then you have to rule out sepsis and metabolic diseases. So for biliary atresia, I said that if the child is very young and you think that liver biopsy is not going to give you the true picture, then you can go for HIDA scan, and depending on that, you can decide. But later on, you can go for liver biopsy or directly to intraoperative cholangiography if the child is near 90 days, so that we save time. So cholestasis is an important cause of CLE, and any child who's having cholestasis syndrome, biliary atresia should be ruled out as soon as possible, so that we don't miss the child surgery of the child. And yeah, there's no single laboratory imaging test that exists which will differentiate biliary obstruction from any other cause of neonatal cholestasis. So at times you can have all the things, but even after liver biopsy, you may not be sure that this is biliary atresia or not. So that time you'll have to resort to other tests like either intraoperative cholangiogram or go for genetic. That's nice.
Thank you, Rimjin. That was, I think, so you did the wrap-up round also. Okay. So residents have got a sort of flair of this cases, and I think because of both of you, Ruby and you, they should do well if they get a case of neonatal cholestasis or jaundice case in the exams are also later on when they start their practice.
Yes.
So, Dr. Surbi, you want to add anything from your experiences?
What I have seen is like when I was also a PG student, so what we used to get scared, like when the INR used to, increase 4, 5, and this especially happens at midnight. there is, the patients, I have faced it, so there is no shame in accepting it. So, we have a instinct to give an FFP. The child is being absolutely stable, and we go, and even I have done this mistake, and I have done my fellowship and gradually learned. Everyone has done that, and I have no problem in accepting it. We've all learned. So I would just say to avoid FFPs in such situations when the child is completely stable, and like you both are smart enough, and your batchmates also, ki, how is the neurological status, everything is going fine. Just avoid giving FFP when it is 4 or 5, it is okay. You are in the hospital setup, and you can maintain the child. So to give FFP, you need to take many things into consideration. Only a deranged INR with an absolutely stable, in the sense relatively stable child with no IVH or anything. I agree there may be some ecchymotic patches in few cases, but usually in biliary atresia it is not there. But even if an INR is deranged, do not rush in and go in for giving an FFP. You can wait. And all these emergencies happen after 8 p.m., 10 p.m. when the residents are alone in the ward, and it has happened with me also. So you can, safely wait. Or, when the child is unstable, then yes, of course, you can definitely take a call when it is a bleeding or something. Then we are not stopping. But if there's no such complication happen, just wait to give, an FFP.
And the
And
harm of
always,
giving yeah. Please continue.
yeah. Sorry, ma'am?
Continue.
Acha, no, ma'am. I'm just saying that this is the most common thing which I have myself faced, and I'm
And
sure they must be also having the difficulties or dilemmas of facing and giving FFPs. And always in these kids, club your investigations together. Just don't go on pricking abhi a. Make a chart. And like in all patients, like you are going to pass out soon. So always club your investigations, because you don't have enough beds to shift these patients to ICU. We face that, right? And ultimately it's going to come on you. So always plan and club your investigations. Minimum pricks in such kids, especially those who are, having hepatocellular diseases. They are at an increased risk of sepsis. तो तुम सबको तो ICU shift नहीं कर सकते. So always club your investigations, and that's how you proceed ahead. Always
the
do
harm
that.
of giving FFP in these patients is that it gives you a false sense of security.
Security.
Momentarily, the INR will improve, and you'll feel that okay, the child is getting well. But actually, the child may not be getting well. The disease is progressing, and after 24 hours, the INR is again going to shoot up. So, if you want to plan for transplant, especially in older children, and if the parents are affording, so you have to see that whether if the INR is shooting up, you should shift the child to a transplant center. If by the time they shift, or by medical management, if the INR comes normal there, that is well and good. But
Well
at
and
least
good.
if it's not coming, then they can prepare them for transplant, early transplant, if
Early
they're
transplant.
affording. So you can start counseling for transplant. If it is more than 4 5, is going rising even after giving 3 to 4 days of vitamin K, it is not improving, then you should start counseling them for transplant. Shift the child to transplant center if they're affording. There they can wait for a few days by the time other investigations are done. If the child is fit for transplant, INR is not going down, then the transplant can be done earlier.
Here we are. I think we are time up, I think so,
Yes,
before
ma'am.
Lirnet throws us out of the room. Okay. So I want to thank Dr. Sangeeta. She's finally switched on her video. And Shivanjan and Datta, you have, I think they have passed the exam, is it? Can we say?
Definitely, definitely, definitely.
There are
Definitely.
many more,
Definitely.
many more things which will help you improve your presentations. Take all those tips which are there. And once again, I thank Rinjan and Surabhi. Thank you
Thank
so
you,
Thank you,
ma'am.
much.
ma'am.
And
Thank you,
Surabhi has
ma'am.
given you the
Thank
tips of how to work on the ward. Okay, please follow those. Okay. All right, so thank you, and I will thank ClearNet for giving us this opportunity, especially with the extended time also. Discussions can go on. There is no end to it. And maybe I would like to see both of you for another case. We will give
Definitely,
it to
ma'am.
you in advance and you can just do it. It was an excellent inputs from both of you. So thank you, everyone. And I'll say that it is coming to an end, this presentation.